Good afternoon. The Senate Finance Committee now has a quorum and we're in session. We have several bills today. I'm going to read the bill order. They are Senate Bill 465, Senate Bill 469, 112, 213, 26, 458, and 290. Senator West is here for the first bill hearing. And I'll just remind everybody that the senator who is the sponsor has unlimited time, whatever time he or she needs, that one person who is the lead proponent will have up to 5 minutes and others will have 2.5 minutes each. So we'll start now with Senate Bill 465, Senator West.
There we go. I think I'm unmuted.
Yes, you're.
Great. Thank you so much, Chair Kelly. And it's great to see the other members of the Finance Committee. It's always a pleasure to appear before you. This bill is really a very simple bill. It's a follow-on bill to Senator Middleton's 2018 bill, which became Chapter 621 that year. Chapter 621 established a pilot program to provide limited dental coverage to adults who are dually eligible for both Medicare and Medicaid. This program is now up and operating, and licensed Maryland dentists are providing care to adult patients who qualify under the program. Some of the dentists who render dental services to patients under the auspices of the program are using dental students at Maryland dental schools to assist in treating patients. This very simple bill merely provides that the Maryland Department of Health shall reimburse a dental provider for Medicaid-related services provided under this program that are performed by a dental student acting under the supervision of a dentist, a licensed dentist. Thus, this bill enables dental students to participate in externships at dental practices that specialize in Medicaid work and incentivizes those students to take on Medicaid patients themselves once the students become licensed to practice dentistry. Now, I noticed that there is some opposition to this bill. It's multifaceted, but I don't think it's insurmountable opposition. I note there are a couple of things that have been suggested in opposition, and I believe a couple of very modest amendments can deal with most of the problems. For example, there's an objection that this bill would permit students attending dental schools in other states, which are not known by the Maryland dental community, to practice here in Maryland. So we could change the bill, and should change it, I think, to specifically say the students must be students at the University of Maryland School of Dentistry, which is the only recognized school of dentistry in Maryland. Let's make sure they're Maryland students who are dealing with Maryland patients. Secondly, there's no reason we can't expand the oversight of the dental board slightly to include oversight over dental students engaged in providing dental services under this statutory provision, should it be enacted. And then finally, there are a couple of other logistical objections, which I think can be easily overcome with the following language, adding that the work needs to be done in a private dental office for a limited time during the student's final academic year, thereby making sure first-year students aren't covered by this bill, when under the direct tutorial supervision of a licensed dentist holding appointment on the dental faculty of the school in which the students enrolled, thereby eliminating dentists who may be sketchy. Certainly if a dentist is on the faculty of the dental school, that is a highly qualified licensed dentist and fully capable of directly supervising students under his or her tutelage. So if there are any other objections that the objectors will raise, we've got 5 weeks before crossover. I would be more than happy to facilitate a meeting of all the stakeholders to work out the bugs in this bill so that we can pass a bill before the session ends, which would respond to the concerns of the objectors, but still accomplish the goals of the bill. Thank you.
Thank you. Let me just ask one question, Senator West. If a student who is learning and in an academic environment in his or her final year is going to be reimbursed through Medicaid, and we really have a lot of pull on Medicaid and not enough Medicaid funds already, won't this hurt many needy people? And wouldn't it be better to reimburse that student through some other kind of an internship or something with foundation funds from somewhere?
That's a good question. I think Ms. McDonough is prepared to answer that during her remarks. So let me defer to her. And I think she comes up next, as a matter of fact. So maybe she could start off by answering that question.
Okay, are there other questions? Okay, let's go to Kathleen McDonough.
Thank you.
You're the lead proponent, you have the 5 minutes.
Thank you very much, Madam Chair, and good afternoon to you and to the members of the committee. For the record, my name is Caitlin McDonough, and I'm here today representing Benefis. Benefis is a dental support organization which provides non-clinical administrative support to dental practices throughout the country. In Maryland, the 9 practices we support primarily specialize and focus on Medicaid patients. And while we would see Medicaid patients under the adult dental pilot that Senator West and our sponsor reference, we also see primarily children because they are the primary population served under Maryland's Medicaid dental benefit. So I did want to point that out. I'm going to get into it a little bit more, but in regards to your question, Madam Chair, the bill would require that not the student be reimbursed under Medicaid, but the provider where they were performing the services. And I think what we see from the Department of Health in their comments on the bill is how this would work is if I'm an extern from university, a dental school, and I'm providing services under supervision at Senator West's practice that provides Medicaid services, his practice would bill for those services the same way they would have were I there or not. It's not that the student is paid or reimbursed. It's just an educational experience for them. So I think that, so it wouldn't expand who's getting Medicaid services or anything like that. It's just kind of the logistics of the billing. So, and on that same note, we see Senate Bill 465, as Senator West said, is a pretty simple bill. And I think you'll see this reflected in the fiscal note, in the informational letter from the Department of Health. And we may actually be seeking some other clarification per the House Committee's request from the Attorney General's office. It's just clarifying something that may already be permissible under current law. So you can already do externships under current law. The health occupations article, has an exemption for licensure requirements for students in an educational setting. So these externships exist. What we ran into when we, some of our practices we support, were in negotiations with the University of Maryland about potentially, this wasn't like a done deal or anything, but potentially participating as a community practice partner in their existing externship program. There was a question that was raised whether the Medicaid regulations permitted it. The Medicaid regulations state that you must be a licensed dentist to perform Medicaid dental services. And there was some question as to whether that definition of licensed practitioner included a dental student, as we see elsewhere in the health occupations article. It was a little ambiguous. And we did, we kind of received some ambiguous guidance from Medicaid. So after going back and forth with them and consulting with the dental board about the scope of practice aspects of the bill, we thought it would be, the clearest path forward would be to clarify the statute through this bill. But what we found since the bill was introduced is that Medicaid has issued a statement, and it should be in your packet, that they believe they can already do this. How it would work is the student would perform the work as part of an externship, and then the supervising dentist would bill for that work. And that's something that happens in private practice with private insurance. It could happen, they bill if someone was paying out of pocket. And now, I think we have some clarity from the department that can happen for Medicaid patients as well. So that's all we see the bill doing. So what I think the bill, and this may be some of the confusion, what things I don't believe the bill does, and I don't believe the department or legislative services believe this bill does, is alter the scope of practice for any dentist or any dental student or any other dental professional. It doesn't expand or increase Medicaid services or any of the scope under Medicaid. This would be the same services that practice is providing now. They just have a student in there to get exposed to those type of services. It doesn't require that any school or student or dentist or practice participate in an externship. And I think what we would be seeking is if there's an existing externship at the University of Maryland, and I mean, with all due respect to our sponsor, I don't know that we'd want to limit it solely to the University of Maryland, because I think we've also been in communications with, say, a Howard University, who would also possibly partner with Maryland dental practices given the proximity. But they have an existing externship program that includes many of the guardrails and safeguards that is suggested by the opponent's testimony, but those are all set by the school and by the externship, not necessarily in statute. And I would also be concerned, I wouldn't want those guardrails to only apply to Medicaid and not apply to other types of externships and create some inequities there. And we actually see Medicaid dental providers as some of the more regulated dental providers in the state, because not only are they regulated as licensed providers under the dental board, they're also regulated by Maryland Medicaid. And I think we all know there's increased administrative burden there. And to that same note, it doesn't remove any current requirements that are in law on externships. It doesn't change anything there. And, you know, in closing, I think, and again, this is something we do in other states. We have participated in the past. I don't think we are currently, but we have up until COVID basically had participated in a similar externship program offered at Virginia Commonwealth University. And they did have a lot of these safeguards in place, and we're happy to comply with them, but they were set by the school and not by the statute. And Ronnie Coleman from Benefits is going to join us today, and I think he can also give a little more background about the specific programs we've participated in other states and that we would potentially be looking to do in Maryland, and just want to make sure we're not running afoul of anything in Medicaid law. But, and I apologize, I don't know, I'm maybe running long on time, but big picture is we think having externs and dental students exposed to Medicaid populations and pediatric populations is a good way to incentivize them to provide those services. They get exposed to the geographical areas, they get exposed to the communities. And I mean, I know my experience is I interned in the Senate President's house or office, and now I'm here every day.
You really have exhausted your time.
Oh, I apologize. So we just want to incentivize those students to do this work. We think it's a good low cost way to do it. So thank you very much. And I'm happy to answer any questions.
Okay, I have some. I've spent a lot of years in academia, and I'm trying to understand how the student is incentivized by the professional who already is affiliated with the dental school program and who's getting a salary already and who is eligible himself or herself to build Medicaid if they actually do the work. How it's helping the student, why we would use Medicaid dollars, which are so limited in this setting. There's so many people who are low income and needy of dental services that and many of them are in settings where they can't get to one or two dental schools. We need services closer to where the people, and they're in all 24 counties and various locations, some with no transportation, some essential workers who need to come at odd hours. I'm just trying to understand why we would want to use the limited Medicaid dollars in a setting such as this, because initially I thought you were talking about paying the students, but you're paying the practitioner who's over.
Yes. And I think that question's spot on. So our office is just as an example. And again, we would just be one potential partner on this. This isn't specific to our practices. We treat about 20%, a little less than all of Medicaid dental services in the state, and about 40% in the Baltimore region. And that's because we have quite a few offices in Baltimore City and in the surrounding regions. And what we picture happening is the students go to the practice in the community and provide services as part of an educational experience under a private dentist, under the auspices of an externship.
Okay, well, let me just ask one other question. I want to move on to other speakers. I'm not sure, you've talked about we a lot, and when I don't see who you are affiliated with, who's the we?
So we support, Benefis is the dental support organization, and we're kind of here on behalf of the 9 practices in Maryland that we support. They're under a couple different brand names, Porter and Pine Dental. So there's, again, I mentioned several in the Baltimore area, one in Prince George's, one in Montgomery, one in Western Maryland, I believe one in Salisbury. I may
So
be
this
missing one.
would be the dentist in your organization who would,
Would
are
oversee
they
a student.
affiliated with a dental school?
They could be if that's what the externship requires. So my
Well,
understanding,
it
it would
just
just be based on what the dental school program is. Again, so we do have, in other states, we are affiliated with the dental school, but our
Okay.
understanding is like the University of Maryland's program where students go into federally qualified health centers and see similar
Are
patients.
you a regional organization or a national organization?
We support practices throughout the region, but I mean, for purposes of this bill, it would be the 9 practices we support in Maryland. Should they choose to participate, they wouldn't be mandated to participate under the bill.
And you don't know yet if these people want to participate.
Honestly,
wait-
when
Okay.
we ran into this kind of hiccup with the Medicaid regulation before we, at the beginning of the conversation. So, I mean, we just wanted to make sure, if Medicaid doesn't allow this and we can't clarify that in the law, there wasn't much point in kind of continuing the conversation. Now, I think we're hearing from Maryland Medicaid is that they do think this is permitted and this would just clarify it. But in all honesty, I mean, if we can have that communication with Maryland Medicaid, there may not be, a need for the bill. And I think that's what we're seeing reflected in the fiscal note. But again, we're happy to have the conversation with all the stakeholders. We just want to clarify.
Okay. All right. Well, you answered. Thanks so much.
Thank you, ma'am.
Okay. Are there other questions of this witness? Okay. If not, then we'll go to Ronnie Coleman.
Hi there. Thank you, Chair Kelly. My name is Ronnie Coleman again. I'm Director of Government Relations for Benevis. We're the support organization that does non-clinical work for Porter and Pine Dental in Maryland and about 140 other dental practices in 15 states. And we're kind of the Medicaid specialist in your states. As Caitlin mentioned, we serve a high percentage of the Medicaid patients in Baltimore and Maryland in general. So going back about 3 years ago, our chief dental officer worked with the externship director for the University of Maryland Dental School to provide opportunities for interested dental students to gain appreciation for the challenges and fulfillment of working with kids in high need communities. Now, our hope was to translate their experiences into an interest in child and safety net dentistry, of which there is a growing and disturbing shortage of these kinds of providers. Because in fact, typically in most states, about 20% of dentists see an appreciable number of Medicaid beneficiaries, unfortunately. So we were planning to participate in an already existing externship program with already established rules and guidelines. But we hit a snag when we learned that at the 11th hour that Medicaid was off limits. We were surprised. The University of Maryland professor in charge of the externship was surprised. In fact, your state Department of Health oral health director was completely surprised. She was emphatic that she believed Howard University had such programs in Maryland, helping in communities. Anyway, Benevis has supported community experiential learning programs focused on high-risk kids in other states as well, including Louisiana at LSU Dental School and Indiana, IU Dental School. We've supported them financially and with in-kind contributions because their programs were so focused on dental students getting experience with kids in high needs communities at Title I schools and so on. In Virginia, one of our dental leaders actually became an adjunct professor at VCU, which is not a heavy lift. We are completely okay with following any rules set out for these programs, so long as the adjunct professorship that's offered is not a huge lift, which would be a burden on federally qualified health center, dentists, and so on. But that's typically not a problem in places that I'm familiar with this type of thing, like in Louisiana, Indiana, Ohio, Kentucky, so on. Anyway, so basically we go to the offices, we have the students accompany our dentist, and they're typically fourth-year dental students that have the opportunity to gain this experience in our offices. In Richmond, that's where we did the VCU experience. So I was literally on a couple Zoom calls within the past 2 weeks for over 90 minutes with the two ladies that actually run the program at VCU, discussing how popular that rotation was when we had it. And we talked about re-engaging in that matter and some other public policy matters with one of the people that I typically talk to. She happens to be Dr. Tegwin Brickhouse, professor and chair of the VCU Department
Okay.
of Dental
And
Public Health
only
and
have
Policy.
2.5 minutes, you've kind of exhausted them.
Sorry. So really the point is, we just want students to have the experience of working with the most challenged kids in our communities. I appreciate your time. I would appreciate your support. And I want to thank Senator West for understanding.
Okay.
And I'm
I
happy to
do
answer any
have
questions.
one other question, and some of my
Sure.
colleagues on the committee might. Oh, what is your mission, Benefits' mission?
Benevis's mission is to provide non-clinical support for dental practices. So basically, when a dentist goes to dental school or a hygienist goes to hygiene school or whatever, I think their focus in general is to provide healthcare. Some of them like to be entrepreneurs and do all the business and all the rigmarole that comes with it, but some don't. So our goal is to do all the stuff they didn't go to dental school to learn, and that's what we do. So we do the financial work for them, HR, we'll do property management, government relations, all of those types of things that typically folks like to hire out for. So
And
that's
so
our
they
goal.
pay you a fee for all of those services that you provide.
That's essentially the way it works, right? That's essentially the way it works. And there's multiple practices around the country that we support. In Maryland, like Caitlin mentioned, it's Porter and Pine Dental. There are a couple other non-medicated oriented practices that we support in Maryland as well. And we're the largest Medicaid dental provider in the country. And without us, there'd be a lot less access to Medicaid in most states.
Okay, it's interesting to know. Are there other questions of this witness? Okay, let's see. Dr. Wang is not here. She hasn't shown. So,
Yes, I apologize, Madam Chair. She was seeing patients this afternoon, so I
okay, so we'll go to Dan Dougherty.
Get unmuted. Excuse me, Madam Chair, members of the committee. I'm Dan Dougherty here representing the Maryland State Dental Association, and we're in opposition to Senate Bill 465. We submitted written testimony, and it laid out a lot of problems that we felt the bill had, many of which were addressed by Senator West. And as always, we appreciate the senator's appreciation of concerns and finding remedies and trying to work with us. But what I have become aware of, and it's frightening to me, is that we have this whole area of externships in dentistry in Maryland that's unregulated. Yes, there's a program at the University of Maryland, which up until recently I thought was the only externship in Maryland, but it's not. It's any dental school in the United States or Canada. Now, there's 67 dental schools in the United States and there are 10 more in Canada. All of them could have very different criteria for their externships. All of them could have different requirements or quality of students that are produced. And the bottom line is, I think we have shown by this bill a massive problem in need of regulation in Maryland. These externships are not regulated by the dental board. They keep referring to law that allows them to exist, but I haven't been able to find any regulation. I know that some dental schools got authorization by the Maryland Department of Education to do things in Maryland, but there's no regulation. The dental board's unaware of them. The dental school's unaware of anything beyond the University of Maryland Dental School. And what is happening? You've got issues of the training of the dentist, whether or not they're qualified to teach. You have the issues of what year is the student. You have issues of what procedures can they perform. Is there disclosure to the patient or the patient's guardian that in fact it's a dental student providing the care? Is there liability coverage if there is a problem that protects not only the patient but the dental student? The list goes on and on and on. And I think the take back from this bill is not only shouldn't this bill pass, But we need, as a dental community and the General Assembly together, to start regulating this largely unregulated area of dentistry and dental education. So that being said, Madam Chair, I would urge that the bill be given an unfavorable report.
Are there any questions? Okay. We now have Charles Doring.
Thank you. Thank you, Madam Chair. Mr. Vice Chair, members of the committee, and always appreciate Senator West. My name is Charles Doring. I am a general dentist in Rockville, area Montgomery County. I am the Legislative Affairs Committee Chair for the Maryland State Dental Association. I am a provider in the Maryland Medicaid Maryland Healthy Smiles program, and I may be able to answer some of your questions. I'm on the Dean's faculty of the dental school. Before COVID-19, I would have 4 senior dental students come individually on rotation to practice general dentistry alongside with me, and also provide care in long-term care facilities. The dental school requires a certain number, I think it's 3 or 4 externships for graduation requirements. I will say care provided, and I'm direct supervision with these students. And I will add, if you read the bill, I appreciate Senator West's comments, not all doers are good teachers. So to be on Dean's faculty or faculty at the dental school, there is a vetting process, as well as a process on selecting the students that come on these externships. Care that's provided, whether it's in the externship or in the dental school, is billed out, whether it's an insurance, Medicaid patient, is billed out under the faculty supervision. So the supervision is the licensed practitioner who's submitting the claim. So I'm wondering whether we even need this legislation. I will ask with Senator West if we want to get together on this. I appreciate that. And we need to talk.
He's shaking his head yes.
A very high level with the dental school, including Dean Mark Reynolds of the dental school, who's not aware of what's going on until I told him. So for these reasons, I would ask for an unfavorable report on Senate Bill 465. Thank you.
Okay, are there questions? Okay, then we're going to Thomas A. Beckett.
Good afternoon, Madam Chair, Vice Chair, members of the committee. I want to thank Senator West for opening this by saying he's willing to look at amendments and changes to do this. And so I'm going off script a little bit because a lot of what I was going to say has been said. But to me, I'm opposed to Senate Bill 465. This legislation to me is like putting the cart before the horse. Earlier this session, you considered Senate Bill 100, the Task Force on Oral Health, that is now in third reader. This is where this should be considered, in the task force, looking at the reallocation of resources so the dollars from Medicaid are spent in a method that is most advantageous to everybody, to the state, to the practitioners, and especially to the patients. So with all these unknowns, I would recommend an unfavorable report for Senate Bill 465. Thank you.
Okay, are there any questions? Okay, well, that ends the testimony on Senate Bill 465, and thanks to everybody who participated. Okay, we're going next to Senate Bill 469, Senator Washington. Okay, let's see. Senator, you have all the time you need, and Judith Ersetti will have the 5-minute slot. Everyone else will have 2.5 minutes.
Thank you. Thank you, Senator. Thank you, Chair Kelly. Thank you, Vice Chair Feldman and members of the committee. Seeing you quite often. Honored to be the Senate cross-file for this important bill. It's being introduced to address an increasing access to critical treatment for autism by eliminating unacceptable inequity between Medicaid families and families with private insurance. So back in 2012, this committee rightly passed and the governor signed into law legislation that established this technical advisory committee within MDH. And they made the decision about they were asked to make decision about the appropriateness of specific coverage, specifically looking at the mandate around the autism spectrum disorder. And it include something that's considered a really remarkable, a good treatment called ABA, which is Applied Behavioral Analysis. Now, the Technical Advisory Committee determined that the coverage for ABA services was required under the state's habilitative service mandate. The results were long awaited for coverage for ABA as autism treatment. The state employees, self-funded plan and Medicaid, and many families were helped as a result. Then in 2014, the Centers for Medicaid and Medicaid Services Bulletin clarified that ABA services for children are required to be covered by Medicaid. So in particular, these benefits are required under early periodic screening diagnostic treatment. So that's referred to as EPSDT benefit program. The bulletin was uploaded with my testimony, so you should have that. CMS writes that states are required to arrange for and cover for individuals eligible for EPSDT benefit any Medicaid coverable services listed in the section, and as long as it's determined to be medically necessary to correct or ameliorate any physical or behavioral conditions, unquote. So please note that states are required to cover these therapies for children, regardless if their parent is willing or able to be present for the service. So after Maryland passed this bill, subsequent state Medicaid regulations mandated that a parent be present during ABA, though this has never been required of privately insured parents, hence the disparity. In Maryland, we've evolved into a system where children in private insurance plans have options for treatment to improve the outcomes for the rest of their lives, whereas children in Medicaid have the door shut on them. The children who are Medicaid eligible also deserve the right for same access. So ABA treatment is so intense that it can require up to 40 hours per week. So Maryland's parental participation mandate only for Medicaid recipients means that families have a really simple and stunning choice they have to make. Do they accompany their child to treatment and provide the best opportunity for a high quality life? Or do they go to work so they can pay rent, buy food, etc.? It's really cruel to have families have to make this choice, particularly families that are parenting special needs children. Early intervention and ABA are proven to improve lives. And in the long run, we believe that it'll save money, including Medicaid money. We have this shared commitment. We believe that there should be equity in our healthcare. And so we need to eliminate this requirement. So again, the bill is very straightforward. It would amend this regulation, remove the barrier to care, and create treatment equity. So for these reasons, I'm asking for your favorable report on Senate Bill 469. I'd like to introduce my panel. As you said, Senator, the lead proponent is Judith Ersetti. She's Vice President of the Community Affairs for the Council of Autism Service Providers. And then Aaron Camp, who's the Regional Director of Little Lee's Behavioral Services, and Rebecca Renzi with Pathfinders for Autism. Again, thank you so much for this opportunity, and I ask for your favorable report.
Thank you. Are there any questions? Okay, then we're going to Judith Ersetti.
Thank you so much, Madam Chair and members of the committee. I'm Judith Ersetti, and as mentioned, I'm Vice President of Community Affairs for the Council of Autism Service Providers. We're a nonprofit organization, and we represent members who are working very hard to provide evidence-based treatments and services for people with autism in schools, in healthcare settings, in the community, everywhere you go. It's so important that evidence-based services are funded and provided, and they can make a huge difference. One of those interventions, as Senator Washington mentioned, is something called applied behavior analysis. And as many of you already know, 1 in 50 154 children are now diagnosed with autism spectrum disorder. So many of our children are being diagnosed now. That's according to the CDC. A big portion of those children will be prescribed applied behavior analysis therapy by their doctors. And it'll be prescribed as medically necessary because they need to learn how to connect to the world around them. They need to be able to learn, how to be safe, how to understand what people are saying to them, how to speak, how to point, how to connect to the world around them. It's so important. As Senator Washington mentioned, we passed a law back in 2012 opening the door for private health insurance to cover this evidence-based therapy. And then a couple of years later, CMS came out and said, hey, under EPSDT, our Medicaid children under the age of 21 should also have access. I worked on all those issues in Maryland and worked on development of the regulations. It's important to note that the regulations require parent training and parent involvement in development of the treatment plan. So that component is still there. What the simple remedy is here is that parents being required to be present at all times during delivery of ABA therapy, that requirement is being removed. So parents will still be very much part of the team as much as they are able and as much as is medically necessary for them, but they will not be required to be present at all times, which can be a barrier. I want to reemphasize that private health insurers do not require parents to be present at all times during therapy. And also other states that have implemented this benefit under EPSDT do not require parents to be present at all times. This is so important for families. EPSDT was written to protect children and to provide therapy for those individual children, no matter what their status is family-wise. So I ask you today to support Senate Bill 469. It's critical for children with Medicaid who are also diagnosed with autism spectrum disorder in Maryland. Thank you so much.
Okay, so a child whose parent is an essential worker right now in the middle of this pandemic and who must go to work or they'll lose their home and all services, could be brought by another adult for treatment and the parent not necessarily have to be there at all times. Is that what you're getting?
That is correct. And the services are provided and supervised by a licensed behavior analyst. So, and we have behavior analysts that can talk about how they do that. So safety, quality is all implemented into the program.
Okay. All right, we're going next to, are there other questions? Okay, then we're going to Erin Camp.
Good afternoon, Chair Kelly and committee members. My name is Dr. Erin Camp. I'm a licensed behavior analyst in Maryland. I'm the chair of the legislative committee for the Maryland Association for Behavior Analysis, and I work as the regional director in the Baltimore area for Little East Behavioral Services, which has provided ABA therapy to children with autism in Maryland for nearly a decade. As I mentioned a few years ago, we were so thrilled to have the Maryland legislature pass those important laws that provided children with autism access to ABA therapy in Maryland. And as a result, so many children are now receiving the therapy that they need. Unfortunately, the majority of the children who are benefiting from that treatment are the ones with private commercial insurance. Only a very small percentage of the nearly 700 licensed behavior analysts in Maryland are Medicaid providers. The structural barriers, like this parent presence requirement, have prevented many providers from being able to accept children with Medicaid, including the organization that I work for. Last year, we spoke extensively with Optum, who's the benefits manager for Maryland Medicaid, to enroll as a Medicaid provider. And when we learned about this requirement for parental supervision of therapy, we knew that it would be unrealistic, if not impossible, for parents to enroll their child in a research-based intensive program like ours, where the children come between 30 and 40 hours of therapy per week. And even if there was some rare event where a parent could be available all week in therapy, we wouldn't be able to accommodate all those additional adults in the building. It would take away of our therapy space. And in this time of COVID, it would certainly introduce additional health risks to our staff and our clients. And Little Leaves is just one example of the many providers in Maryland who are not able to provide therapy to a more equitable distribution of clients. This story has been echoed by hundreds of other providers and families across the state. The group of behavior analysts in Maryland are dedicated ABA providers who've been called to create meaningful differences for our community, and we're committed to doing that for all the children in Maryland, regardless of their source of funding. Elimination of the parent presence requirement would greatly increase our ability to serve Medicaid children, and it would help eliminate disparities created by this requirement. We think this bill is a step in the right direction to address a multifaceted problem with access and to improve the health of our youth and of all Marylanders. Thank you.
So if I'm understanding right now, a kid who needs Medicaid funding in order to get the therapy that they need would need a parent who is free for maybe 40 hours or more per week to be at all times at the therapist sessions.
That's exactly right. So we run a center-based program where we provide early intervention therapy for young children with autism, and they come all week. And they're in one-to-one therapy. So children with private commercial insurance, their parents come and they drop them off on their center, and then they are able to go to work and do whatever, and their kids receive this intensive therapy all week.
So there's a greater impediment for poor people or working parents than for parents who have private insurance and are better off.
Yes, ma'am. And this requirement is saying if you are a Medicaid parent, you need to come and sit in my waiting room all day, all week, if you want your child to be able to come to therapy.
I see. Okay, are there other questions?
Madam Chair?
Yes.
Could I just ask, what's the stated reason for that? Like, why is that in there? Is there,
There are some best practice considerations for how parents are involved in ABA therapy, and good ABA practitioners involve the parents heavily. We're in caregiver training every month. We're providing access to showing therapy, doing therapy at home, communicating with the parents. The parents tell us what's going on. We teach them how to do things that are going on in the home. So parent interaction in therapy is part of best practice. The idea that a parent would sit and watch every minute of every session is what's different in this regulation than in any other. And what we don't want is, for most of our families, I push really hard for that family involvement, caregiver training, generalization, but not all families have that possibility. And if a family isn't able to participate in the way that we want, that still doesn't mean that their child doesn't deserve therapy.
Would there, I mean, I agree with you. And I've toured I've toured a great facility, not in my district, but just outside my district that some of my constituents have students at. And so I know how intensive and important the ABA process is and what you guys do, at least I know a little bit about it. So I guess trying to find common ground on maybe a requirement, some level of requirement, but not the one that the parent has to be there the entire time. That's interesting. I was just curious if they had a reason. So it's a best practice thing, but it sounds like maybe it's being taken to too far of a conclusion by saying they have to be there all the time.
That's exactly right. For most commercial private insurance, they ask us, they ask us to have caregiver training once or twice a month versus this all day, every day.
So they really are asking people who probably are most overloaded with fewer resources if their children need therapy to sit there as if there's nothing else in the world that they have to do. Whereas better off parents with private insurance can be trained and can be involved and can be co-helpers without that significant commitment of time every day, every session.
That's exactly right.
And Senator, and also to Senator Reedy, I do think this is an unintended consequences. I think the COMOR regulation was meant to, I'm believing that the regulation was meant to just fully engage parents, but it just went a little too far. So we would not be removing participation at all from the COMOR. It's just saying like, look, you can pay for it using Medicaid. Because right now they're just not able to. So is that right? That's correct, Ms. Camp? That, I mean, just want to assure the senator that we're not removing any requirements, that it's just allowing Medicaid to bill as long as there's another adult or somebody there.
That's exactly right.
Okay. And I see a number of kinds of practitioners and organizations. If you guys take a look, all in favor, and I don't see any unfavorables listed. So it sounds like maybe we got it right, Senator. Okay, thank you very much. That ends the testimony.
Thank you.
Oh, wait a minute. No, we do have one more person. Rebecca Renzi.
I've two, yeah.
Renzi.
Thank you, Madam Chair and the members of the committee. I'm not sure I have anything more to add, but I will share my testimony with you. I am Rebecca Rienzi. I am the Executive Director of Pathfinders for Autism. We are a Maryland organization dedicated to helping individuals with autism and their families through resources, training, and recreation. And last year, we served over 19,000 Maryland residents, yes, during a pandemic. And I'm here today in support of Senate Bill 469. As noted, ABA is a common behavioral therapy that can help people with autism to reach their full potential. And the Medicaid requirement that parents be present during ABA services is arbitrary, burdensome, and creates inequity in the access to medical care between those with private insurance sold in Maryland and recipients of Medicaid. It puts the parents in the position of having to choose between work and other family obligations and getting the medically necessary treatment for their child. Judith noted in her testimony that the prevalence of autism at the national level is 1 in 52 children. Here in Maryland, the prevalence is 1 in 54 children. We have over 12,000 children in Maryland public schools diagnosed with autism, and 1/3 of children in Maryland are covered by Medicaid. So if you do the simple math here, that's a lot of children that are not getting equitable access to treatment, which has already been noted was mandated by CMS in 2014. The requirement that a parent be present for service is not clinically necessary or appropriate, as Aaron shared. It was not required under the 2014 mandate that made ABA coverage a requirement under private policies, and it was not included in the Medicaid state plan amendment that was approved by CMS in 2017. So under this rule, Maryland Medicaid is creating systemic barriers that inhibit access to medical care for thousands of the most vulnerable children in our state. Beyond the issues of equity, the requirement is fiscally irresponsible. It forces parents, again, to choose between employment and treatment. Employment that may reduce that family's need for public assistance programs, and treatment that could, over time, reduce the child's need for special education services and adult service programs covered by the state. So I respectfully ask that you vote in favor of Senate Bill 469.
Thank you. Are there any questions? Okay, I think we learned a lot. Okay, we're going next to Senator Lee, Senate Bill 112. Senator, you have all the time you need to explain your bill.
Okay.
Your lead proponent is Hannah Abrams, who will have 5 minutes, and other
Okay.
will have 2.5 minutes each.
Okay. Thank you, Madam Chair. And SB 112 is a compromise bill containing some of the negotiated provisions from last year's SB 201. Notably, this year's bill does not include provisions on geolocation or activity tracking in private sector due to the nature of this session and some vocal opposition last session from the private sector. So we've been in the interim working together with some of the stakeholders. Due to the importance of some of the agreed underlining measures within the bill, we are not pushing those measures at this point in time. The two remaining provisions in this bill update the definition of genetic information, and the second cleans up the process of reporting data breaches, so victims of the breaches are aware that they are vulnerable as quickly as reasonably as possible. As you indicated, Hannah Abrams is here from the Office of the Attorney General, and you can see her written testimony discusses the specifics and the particulars of the bill very clearly. The bill is cleaned up from our efforts last year and does not push the barriers of law in Maryland past any precedents in other states as amended. As a reminder, this bill was a compromise from last year's version. And to demonstrate that effort, we have Sean Looney from Comcast and others representing affected industry supporting these efforts. Any objections you may read in testimony have largely been confronted in my proposed amendment. You should have a copy of the amendment. Your offices should have access to it. I hope that you do. If you don't, let me know. Unaware of any opposition at this point to that language in the amendment, the House subcommittee, the House version of the bill, the subcommittee has already voted out the cross file with this amendment as well. This is, of course, low-hanging fruit in this ripe subject matter, and this is fundamental process improvement is very important. The updates in the Maryland Personal Information Protection Act, which I refer to as Mpipa, still included in this legislation, are raised in response to changes in the type of data being collected about consumers and the seemingly constant slew of data breaches. When our data is used for services we seek, the misuse of that data must compel service providers to notify us as soon as possible, or they are doing all the consumers a disservice, as we believe. Data breach notifications are an important method for the public to know that they are vulnerable to identity theft and the disclosure of personal information. Under the current law, if a company that maintains data, that is, discovers or is notified of a breach, they have a maximum of 45 days to notify the owner/licensee of that data. Our bill changes the cap to 10 days. This is reasonable because there's not much the maintainers of the data are required to do at that point, but just tell the licensee of the breach. This bill maintains the notification threshold of 45 days from the time of the discovery, but clarifies that a company is required to notify consumers that a breach has occurred unless that company makes an affirmative determination that harm is unlikely to result from the breach. Prior to consumer notification, the licensee or owner of data must report to the Office of the Attorney General a description of the breach and how it occurred, the scope and breach and the number of Marylanders affected, and a draft of the notification that the company plans to share with affected consumers. Any sensitive information would be shielded from PIA requests. The bill also adds a requirement that a business that maintains the personal information of a Maryland resident implement reasonable security procedures that are appropriate given the nature or size of that business collecting that information. This requirement is already in existence for data owners and licenses. Adding the requirement for maintenance of data is simply a clarification. As a reminder, I indicated there is an amendment, which we should have shared with you, and that we are pushing to mirror with the House cross-file bill HB 148 that's already moving through the House. For these reasons, I urge my wonderful colleagues to vote favorably on SB 112 as amended. Thank you, Madam Chair.
Thank you. I don't know if other members have some questions, but I'm not sure I understand altogether who does what in this bill. If I have a service and experience a data breach as a consumer, what does this bill do for me, or what do I have to do that at the moment is not required?
Right, that is a good question. If you are the owner of the data, you're a business owner or you're the licensee, you have 45 days from the time you discover or notify of the breach to notify the consumer that there has been a breach. If you are just a maintainer of the data, you have 10 days from the time you discover or notify the breach to notify the owner and licensee of the data, so that that owner or licensee can notify consumers of the breach. So it's just merely updating our current Mpipa law to make it. Many other states have already done this, and we worked with some stakeholders, including Mr. Looney, Comcast, to come up with what you see right now.
Okay, are there other questions of the sponsor? Senator Augustine.
Thank you, Madam Chair. Senator Lee, what happens if they don't do it? If they don't provide the,
There are some sanctions, and I'll let Hannah Abrams of the Attorney General's office tell you what they are. Their office enforces the provisions of this bill. If you'll just bear with us, as she knows the particulars and specifics of this bill.
Thank you.
Okay, are there any other questions? Okay.
Thank you, esteemed committee.
We're going now to Hannah Abrams. You have 5 minutes.
Thank you, Madam Chair, members of the committee, Vice Chair Feldman. My name is Hannah Abrams. I'm an Assistant Attorney General in the Consumer Protection Division of the AG's office. Thank you all for letting me speak today, and I'm happy to answer any of your questions at the end. The Maryland Personal Information Protection Act, or Mpipa, is a data security statute. It asks that businesses that collect data from individuals maintain reasonable security practices and procedures that are appropriate to the nature of the personal information. SB 112, with the proposed amendments that Senator Lee has introduced, amends Mpipa and in 2 or 3 ways, let's say. First, it adds genetic information to the list of personal information that businesses are obligated to maintain securely. It also updates some of the notification timelines and requirements. The genetic information addition is important because it's no longer your doctor or healthcare provider that's simply collecting your genetic information. If a doctor or healthcare provider collects it, they have obligations under HIPAA to maintain it securely. Today, we have direct-to-consumer businesses that offer people insight into their ancestry or medical risks based on a swab of their saliva. Now, that could be very interesting, but it also poses a serious security risk because those businesses have, at the moment, no obligations to maintain your data securely. This is not an abstract concern. Direct-to-consumer genetic firms have already been the targets of breaches. In 2018, MyHeritage was breached, revealing the email addresses and hashed passwords of 92 million users. In July 2020, GED Match was hacked and user profile privacy settings were overridden. So that's users had decided that they wanted their information to be private, and the hackers triggered it so that they were no longer private, unmasking over 1 million accounts. Now, this bill was drafted to create parity between those healthcare providers and these direct-to-consumer businesses that collect genetic information. The rationale is that a private company should have the same obligations as any healthcare provider. And to that end, we drafted it using the definition of genetic information that is found in the Genetic Information Non-Discrimination Act, or GINA, which was enacted in 2008, and it has specific definitions in its omnibus bill from 2013. And we wanted to make sure that the language was the same and that the obligations were the same. Now, back to the July 2020 breach that I mentioned a few minutes ago. Technology now allows us to decode encoded data. So that data, GED Match told consumers, don't worry, your data was encoded. Just last week, the New York Times published a story about taking cell phone data that was anonymized, so that should not have been identifiable to any individual. And all they had was pings from smartphones without any names or phone numbers. They took that data and were able to track dozens of owners to the devices and track them throughout the day. So even anonymizing the data does not protect it. So we would like that, this bill does not restrict companies from collecting their information. It does not limit what they can do with it. That would be a whole different bill that we can talk about another year. All this does is add it to the list of types of information they're required to protect and maintain securely. And as I said earlier, it's reasonable security practices and procedures that are appropriate for that type of personal information. Now, SB 112, as Senator Lee mentioned, also updates the notification timelines. My office's experience has been that it often businesses delay their notification. SB 112 shifts the trigger to the discovery of the breach rather than the conclusion of the investigation. And this is a trigger that exists in many other states: California, Florida, New Mexico, Ohio, and others. The bill also fixes the consumer notice and the notice that the AG's office gets, explicitly telling what information we have to be notified about. And it also asks that big companies who have chosen previously to use substitute notice because it's cheaper or easier don't have that option anymore. We found that after the Equifax breach, it was clear that Equifax was trying to use substitute notice. Many consumers did not receive the appropriate notice as a result of it being a substitute public notice rather than an individualized consumer notice. And so we've asked that that option be removed. And we've had a lot of the tech coalitions agree to the new revisions as according to the amendment that Senator Lee has introduced. Thank you.
Thank you. This is very interesting. Sounds like something that's definitely needed. Let me just ask, if one of us went to ancestry.com or something that is going to use very personal and private data, which ought to remain in our domain, and there were a breach, does this bill suggest how much time the company has to notify, and what other things must the company do?
This bill shifts the trigger. It used to be they could take their time to do the investigation, and once that investigation was done, then that started the clock to notify consumers. This changes that, to the trigger being the discovery of the breach. They have 45 days to notify consumers. And there are certain exceptions. For example, if law enforcement is conducting an investigation, that tolls the clock. They do not have to notify until they have 7 days after law enforcement concludes their investigation. And that's 7 days on top of whatever time has passed thus far. So let's say that a breach happens on January 1, and law enforcement is conducting its investigation. In the meantime, the company can prepare its notices to consumers. And the law enforcement investigation may take a month, it may take 2 months, it may take 3 months. After they get you're good to go, they have 7 days to mail out the pre-prepared consumer notices.
Okay, so they've got time limits on them for notification, and they must do it individually to the consumers who've been impacted and not just put something in a newspaper general notice.
Assuming they have the right contact information and the right information, but yes, they still do have that option to do it on their website or in the newspapers if they don't happen to have individualized contact information.
Okay, thank you. Senator Kramer, and then followed by Senator Augustine with your questions.
Thank you, Madam Chair. Ms. Abrams, what entity in state government will be responsible for enforcing this act?
The Consumer Protection Division currently enforces Mpipa, so that would continue.
The Consumer Protection Division of the
Office of the Attorney General. Yeah, and let me back up actually. What this act already does is it makes a violation of Mpipa a violation of the Consumer Protection Act. And so that is the mechanism by which the enforcement lies in the Consumer Protection Division.
In light of so many other areas where the Attorney General's office is failing to enforce current laws that this department has responsibility for now, how is it that the Attorney General's office is going to be able to enforce these provisions?
This does the enforcement authority already exists, and the Consumer Protection Division currently enforces this and has many cases that
They
we've
may be
closed.
charged with enforcing it. Is the Attorney General's office actually enforcing it? Because, as I indicated, there are certainly other state laws that the Attorney General's office is in fact responsible for enforcement and is completely failing to do so. So is the Attorney General's office going to enforce this law should it be passed?
Well, we currently enforce it. We have had many settlements that are public. There was Home Depot last month, Equifax. There are many others that have been settled already that are public. And so that is part of our jurisdiction currently, and we currently are actively enforcing it.
Thank you, Madam Chair.
Thank you. Senator Augustine.
Thank you, Madam Chair. Senator Kramer really touched on the space where I precisely was headed as well. Ms. Abrams, do you feel that, I understand what you said, that you had some of the cases that you were working on. Do you think that you are able to cover the breadth of the potential situations that are out there within this space, just considering how many different entities have the information that this current law even covers? I mean, it's pretty vast as far as who has all this kinds of information that is. How do they get that to you? I mean, how is that even occurring, considering how vast it is?
So they're required to notify us when there's a data breach, and we may review these cases. It is vast. I agree with you. It is a serious problem, but it's an important problem, and we do our best to enforce as many of these laws as possible. We are a lean office, but we work very hard, and we, the only alternative, it would be to create a private right of action, and I'm not sure that you will get industry to support that.
Well, that's maybe because we've had this conversation. Well, no, and we'll continue that conversation.
I wouldn't oppose that, but
no, I know you wouldn't.
I am not going there.
I know you
right
need all
now.
the resources we can get in order to protect Marylanders for situations like this, and I know that is the case. If they did not do it, right, and so we don't know. Because what is the penalty? They don't do what they're supposed to do. That's what I asked before. Like, what is the penalty where they actually did not follow even the current law?
It's a violation of the Consumer Protection Act, and the penalties there could be applied. There's a multi-factor calculation there, and I think it could be up to $10,000 per violation.
Okay, thank you so much. I appreciate it.
So before I go to the next witness, is there any relief for the individuals in some sort of a mass settlement who might be impacted when you are able to prove that a breach has occurred and was not properly handled?
So it really depends on in a settlement context. You mentioned a settlement. That is something that's negotiated based on the specifics of the case. But obviously, our purpose is to protect consumers, and so that is part of our thought process.
Okay, thank you. All right, we're going next to Sean Looney from Comcast.
Good afternoon, Madam Chair, members of the committee. Sean Looney from Comcast. Great to see all of you. I miss seeing you in person, but we'll just have to make the best of this. I want to thank Senator Lee and the Office of the Attorney General for working with Comcast and many other industry members on this legislation. As you could hear from her testimony, it's a complicated issue. We've been working on this one legislation for about 3 years, I'd say, trying to get it right. And, with data breach notification, it's always a balance of making sure you notify in a timely manner and you don't get into over notification, because we've seen in other states where if there's too much notification, the consumer starts ignoring it, and then you've defeated the purpose of data breach notification. So we've had long meetings and lots of discussions about this, especially during the interim, and we finally came up with this compromise legislation. So again, I just want to thank the Senator, Michael, I know he's listening, and Hannah and the Attorney General's office for working with industry on this to reach this consensus. So thank you.
Thank you. Are there other questions of this witness? All right, then we're going to Kaylee Locklear, Maryland Retailers Association.
Good afternoon, Madam Chair, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Retailers Association, here in support of this legislation and the sponsor's amendment that she shared as well. I do want to touch on something else that we've brought up in this conversation, and I just want to make it clear that in no way am I trying to get in the way of this bill's passage. So we understand if you can't take this up now, but because the bill is focusing on streamlining notification, it does seem the appropriate time to have this conversation. So the one remaining area of concern with us is regard to the actual notification section. Currently, notification can be made via phone, written, or email, but only via email if a consumer has opted in to receive emails. And we would like to see the opt-in section removed that's currently in statute. Email is one of the most effective and cost-efficient ways if a business has an email to make notification. And I want to make clear, an email with regard to this in no way is marketing. It's not selling anything. It's just trying to achieve that goal of notifying a consumer about a breach. And I just like to point out, many consumers' phones now block junk calls. My phone is doing it all the time for me now. And then consumers do tend to throw away what looks like junk mail. Neither of those modes of notification, by the way, and you're aware, required some type of opt-in consent from a consumer. So all notification has challenges, but email really should be considered without opt-in. And a business there could include a link for more information, credit services for free, things like that. So I'm glad to continue to have conversations and work with the sponsor and committee on that. There's also just a conversation about what happens, and retailers are considered the owners of data. I just thought I'd throw out to the committee, we have to pay fines for breaches with regard to credit card contracts that we sign. On top of that, retailers end up being sued by a multitude of financial institutions for the cost of data breaches, typically settling those cases out of court for tens of millions of dollars. And then I also just want to point out to all of you that outside of the violations that occur at the state level for not following these protocols, retailers also have data security standards under federal law, the FTC Act in Section 5. So I thought I'd just throw that out there to everybody as well. And we urge a favorable report. Thank you.
Okay, are there any questions? Okay, well, we also have some written testimony, but this ends the oral. Andrew Kirkner, National Association of Mutual Insurance Companies.
Hi, good afternoon, Madam Chair, members of the committee. Andrew Kirkner on behalf of the National Association of Mutual Insurance Companies. I appreciate the opportunity to speak to the committee here today. I'm signed up as unfavorable on the bill. I think my comments or concerns could be best characterized as technical, but I do think there are maybe one or two substantive points that we'd like to make to the committee. Just by way of quick background, NAMIC represents more than 1,400 member companies, 11 of which are domiciled in the state of Maryland. So as I'm sure you're aware and the committee's aware, insurers deal with a lot of data and they are subject to this law like other industries. You heard the overview of the changes in Senate Bill 112. We take no interest or position in the genetic piece of this, so my comments are focused exclusively on the notification provisions. The first area of concern and the basis for our request for an unfavorable report is the shift of the trigger for notification of breaches. You heard the representative from the Attorney General's office describe that change, but in essence, under the existing law, an insurer has 45 days from the conclusion of the investigation. This bill, Senate Bill 112, changes that to 45 days from the date of discovery. Certainly understand what the intent of that change is, but it really ties the hands of the parties that are regulated here to get that notification out. So just to break that out a little further, oftentimes these are complex situations. The investigations take time, and there are a number of steps that companies, specifically insurers, need to take, including perhaps notification under federal law that may apply before they make that notification. So we think that is a concerning change represented in Senate Bill 112. I think you heard expressed that sometimes companies take their time. That was one of the quotes used earlier. I understand the concern there, but we do, as insurers, want to make sure we're being thorough and disclosing those breaches where harm does occur. The other point I'd make, Madam Chair, just very briefly, is the shift from 30 days to 7 days in the case of a law enforcement investigation. So, and hopefully I'm describing this correctly, but under existing law, an entity has 30 days after receiving the go-ahead from law enforcement to make the disclosure. And this is in a scenario where the disclosure is held up, or the notification, I should say, is held up at the request of law enforcement. This bill reduces that to 7 days. We think that's overly constricting, and so we're concerned about that as well. The final point, Madam Chair, and I appreciate the time today, is on the shift on substitute notice. So under existing law, insurers or other regulated entities can make direct notice or substitute notice. This bill, in essence, eliminates that and would create a mandatory notice for both. So in other words, it's no longer a substitute notice. It is notice in two separate areas. So we have some concerns there. I understand there is an amendment that modifies that language. So thank you again, Madam Chair, for the opportunity to appear.
Thank you. Are there any questions? Okay, if not, then that ends the testimony on this bill. Good luck, everybody. Okay, we're going next to Senate Bill 213, Senator Ellis, State Highways Designations, President Barack Obama Highway.
Okay. Thank you, Madam Chair. Chair Kelly, Vice Chair Feldman, members of the Finance Committee. Arthur Ellis, representing District 28, Charles County. I'm here to present Senate Bill 213 to you. It's a simple bill, one page, 2 lines. Original intent of this bill was to rename Route 210, the Indian Head Highway, to the President Barack Obama Highway. So I have a little presentation. I'm not, if the staff could have that going on the screen. Thank you. Okay. So this is Route 210 to rename the highway President Barack Obama Highway. Next slide, please. The purpose of this bill is to require the State Highway Administration to designate a certain highway as the President Barack Obama Highway, which is Indian Head Highway Route 210. Next slide, please. Before his presidency, Barack Obama was elected to the Illinois Senate in 1996. Of course, he ran for the US Senate 2005 and became president, 44th president in 2009 all the way through 2017. Of course, the first African-American president of the United States. Next slide, please. A lot of us familiar with a lot of his achievements, and including the Nobel Prize and just tremendous legacy. For 8 years, no conflict in his administration, just a person most of us believe we could be very proud of. Next slide, please. And thank you for that. We have this bill, and there might be some wording issue versus designation versus rename. And so Senator Patterson, who represented District 26, and myself are both sponsors on this bill. And our intent was to rename that highway. So I'll end and ask for your favorable consideration. I'll follow up with a clarifying amendment and open to any questions. Request your favorable vote for this bill.
Has the general population in the district where Highway 210 is been notified? Have they had a say?
Well, I've had several town hall meetings, and could I say also that we have someone in the House have put a similar bill to rename the highway. I'm speaking to a lot of the interested parties about this.
Okay, are there other questions? Senator Benson.
Yes.
Last. You got to unmute yourself. You got to unmute. We can't hear.
Okay. Okay. Thank you very much.
Now. Okay.
Thank you, Senator Ellis. Now listen, 210 is a worry for all of us in the metropolitan area. The highway is probably one of the most dangerous highways in the metropolitan area. And I do worry just a little bit about that. Do you think that renaming this highway will help to improve, first of all, the perception of 210? Of course, a lot of construction is taking place there. We've done every trick in the book relative to 210. I'm just wondering how this is going to help to promote the image of 210 because it does not have a good reputation. Do you think that will help?
Thank you for that question, Senator Benson, and for your knowledge of that highway. The worst highway in Maryland, just a lot of terrible accidents, a lot of issues that I must say we've worked on here in Annapolis in authorizing speed cameras on that road. The county has really dedicated, Prince George's County and Charles, a lot of resources on that road to fix it. So, the thing is, we have an opportunity to rebrand that road. We need to rebrand it. We need to continue the safety improvements. The overpass that's going there will help. We need to work on more overpasses. We need to decrease the stress because that road is very stressful in that it is home to the worst traffic in the nation. And so there are a lot of issues which we're working on, which we've brought before the General Assembly to fix. So we're working on a complete holistic fix for that highway, that stretch of highway. And the follow-up bill that's coming up, it's another major part of it to clean up the highway. And that's an issue right there statewide. But we have to work hard to do a lot to fix a lot of these things that are wrong with Indian Head Highway. And I believe, this will kind of increase the awareness and bring attention to that road and just rebrand it and hopefully make that one of the safest highway in the country.
Thank you.
Okay. We have questions from Senators Hershey and Augustine in that order.
Thank you, Madam Chair. Just a quick question. Seems like a local piece of legislation, certainly not opposed to it, but in the testimony from Department of Transportation, they mentioned that they have a established policy and procedures on which roadways can be dedicated or renamed. That would go through the Maryland Transportation Commission. Have you tried that route?
No, I haven't.
Okay, was there a reason not to, or just why not, I guess?
Well, of the several routes, the most, to be honest with you, I'm a state legislator and, many other renaming occurred with legislation. Most recently, the Nice Bridge is now the Nice Middleton Bridge, which connects Charles County, Maryland to King George, Virginia. So this is a route that has been taken before, and I just decided in consultation with Senator Obi Patterson to take this route.
Okay, and then finally, just to follow up on the chair's question, is this something that, again, you and the Senator Patterson have decided on your own, or is this something that the community has come to you with, or what's the process there to make sure this determination is correct?
Well, okay, excellent question, Senator Hershey. And so the thing is, being a member of the community, being aware of the debate over the many years I've lived in Charles County, driven on Indian Head Highway, Route 210. We're in discussions with the town of Indian Head. There's a move underway to change that name of that town, and that it's a different process they have to go through because Indian Head Town is incorporated, and so they have to do that. We have sponsored a support joint resolution for them this year to do that. So with the equity movement we have now, with the Washington football team finally changing their names after they said, they'll never do it, with Native Americans in Southern Maryland pushing for the change of the town name and the highway name over the years. There have been a lot of discussions. We've been part of it. Had a meeting with Commissioner Thomasina Coates and the town of Indian Head mayor, meetings with Native American groups. It's a well-studied, well thought out. And I mentioned earlier, there is a bills over the years been put in the House to really do something similar. So a lot of talk. I've been involved in a lot of meetings about this issue.
Okay, all right, I appreciate that. Thank you, Madam Chair.
Thank you, Senator Augustine.
Thank you, Madam Chair. Senator Ellis, thank you for bringing forward this, legislation. I think that we want to definitely, Indian Head Highway is really a very, very, it's dangerous, like Senator Benson said. It's just a bottleneck. It's a lot of concerns for us in Prince George's County for sure around that stretch of road. And obviously, I would be very supportive of the change of the name. My question for you is whether or not the Prince George's County Council and the associated folks have been kind of consulted on this. We have, as a county, invested a tremendous amount, actually, not just in the improvements for that part of Indian Head, but just that part of the county. And there are extensive plans. There have been extensive investments that have been there. And I'm wondering if you've been in touch with the folks inside of Prince George's County, for this very, listen, I'm with you, but these are things that I think are important, that we have to go back and answer for in our county. You know what I mean?
Yeah, understood. And so I'll just bookend my previous answer saying, Senator Augustine, thank you for that question, is that, speaking with Senator Patterson, his district and mine are the two that run through that. So he's my principal contact with that. Over the years, I had informal discussions with county council members. Of course, because of the pandemic, with basically events, meetings, stuff like that, it's been really a whirlwind. So I haven't had a formal request with the Prince George's County Council to seek their opinion on this. Anecdotally, I believe I would get their support. But to answer your question 100% directly, no, I didn't put in a formal request to the council for a support.
Thank you, sir. Appreciate it.
He's here from Barry. Okay, we also have a witness, Rico Newman. We could hear from Mr. Newman.
Well, thank you, Madam Chair. I'd sent a letter previously about some of what I know about Indian Head Highway. I had the job, I traveled that road in 1961-62 when I was working at what was then called the powder plant. And I know that several of my coworkers lost their lives traveling that road, especially during the winter. I've traveled it recently because I still travel down that road to visit my sons who live in Charles County, and the road is still a disaster. That's another issue. The issue that I'd like to discuss is the changing of the name. Working for the National Museum of the American Indian for 9 years, my job was to do research. And one of the letters I had to respond to was about the name of that highway. And going back in history, and I hate to give y'all any kind of a history letter because I got chastised at one of these delegate meetings that had about daring to give history lessons. But it's important about that name without bringing up some of its history. Coming out of what is today Anacostia, which was the Kashtank, that road was known as the road to fair justice. It traveled between the Kashtank and Mayonne, since there's been extended called the Indian Head Highway. We are happy that many things have happened both in Prince George and Charles County, both with the ending of the professional football team's name, getting rid of Columbus Day, being changed to Indian Heritage Day. But we don't want nails put in our coffin to where we disappear from plain sight. I have put forward to Senator that the name be changed, because certainly knowing both of the popular myths about the origin of the name, neither one bear any validity. That it bear a name that, and I recommended Piscataway Conoy Highway. I don't think 3 syllables that way or 3 syllables with Barack Obama Highway makes any difference. And I have the utmost amount of respect for former President Obama. And going through some things, I found that there's now currently a new elementary school being named after President Obama. And checking anyhow, there's a professor out of Rice University that says he has caught up with and passed most presidents, with the exception of George Washington and Abraham Lincoln, and places and sites being named for him. So it's no dishonor for one place to not have that name. What the Professor Rice did note was that every place that has been named for him, that bears his name, there's a connection. There's some connection to his name to those places, and whether it's a school, a place in Chicago, California, where he went to school, or New York, or wherever, there's a connection. Even some islands in the Atlantic bear his name, but these are places he's been, and these are places that honor that presence by giving a name there. I don't remember him ever traveling down the Indian Highway. But that being said, it's just my voice here, and I'm a member of the Chaptico Band of the Piscataway tribe, and I was present at the meeting in 2003 when Commissioner Reagan brought the issue up of changing the name, and he almost got the commission shut down for having the audacity to even suggest it. But we've come a long way since 2003. And again, I have utmost respect for former President Obama, but I would just like to see another nail pulled out of the box that we've been put in and keep some type of native name on it. Thank you.
Okay, very informative. I wish we had more time for everybody, but we don't. Is there a Barry Wilson?
No, he didn't show up.
Okay, I guess he didn't show. So that ends the oral testimony on Senate Bill 213. Thanks to everyone. Okay, we're going next to Senate Bill 26, and Senator Ellis, you're on again. You've got unlimited time to, as the sponsor, and the person on your panel who has the 5 minutes is Jennifer Roberts, and then there are others who have 2.5 each.
Okay, thank you again, Madam Chair, Kelly, Vice Chair Feldman, members of the Finance Committee. Arthur Ellis to present Senate Bill 26 to you. It's requiring State Highway Administration to pick up the litter on the highways on a regular, consistent basis throughout Maryland, and to mow. It's a shame that we need this law, but throughout this bill hearing, you'll understand it goes beyond having nice roads to drive on to look at. It affects our health and our strength and our success here in Maryland. I have a slide on this bill also. If you could please begin the slide presentation. Yeah, the State Highway Administrator. Thank you. Senate Bill 26 having to do with the state regularly picking up the trash and then cutting the grass. Next slide, please. The purpose of the bill is to require the state highway to collect litter and mow the grass along the state highways and the interstates within Maryland. It also requires that the administration seasonally adjust the frequency in which the mowing occurs, subject to certain requirements. Next slide, please. The administration must also contract with certain companies to give them preference in awarding these contracts to cut the grass and to clean up our state roads. It also specifies on this bill that the provision of litter collection and mowing services be considered a supplemental environmental project for certain purposes. Next step, please. Next slide, please. The bill calls for the collection of litter and mowing at least twice a month during the growing season. When mid to late spring, the grass is growing fast, to collect the litter, pick up the trash, and then cut. Number two, collect litter at least twice a month outside of the growing season, weather permitted. So wintertime, late fall, winter, early spring, the grass is not growing, doesn't need to be cut. So this bill says just pick up the trash at least twice a month. And very important, if mowing will occur, the state highway must pick up the trash before they cut the grass. I am insulted, I'm disgusted. Many times I'll see the high grass being cut by those big combines and the trash is cut up in many pieces, spread all over the median and the side of the road. And it's just disgusting. I mean, I have a home, I'm a homeowner. I've never done that in front along the streetscape of my home. I pick up the trash first and then cut. Next slide, please. The administration must also contract with Maryland-based company to collect litter and provide mowing services. When awarding a contract, give preference to companies based within the county and companies that hire former incarcerated individuals. Next step, please. Next slide, please. The trash, it's more than a eyesore. Where does it go? The litter ends way up into our bays and waterway and causes tremendous stress on our beautiful rivers like the Potomac River, the Tucson River, and of course the Chesapeake Bay. Next slide, please. The result of a 2019 study indicate there are 51.2 billion pieces of litter on roadways nationwide. And this majority, 91%, is less than 4 inches, so it's tiny pieces. Most of those resulted from being chopped in pieces before the lawn is cut on the roadway. Next slide, please. According to this website, don'ttrashass.com, more than 25,000 car accidents a year are linked to litter, scores of which results in fatalities. Litter impacts car insurance rates because thousands of auto accidents are litter related. I know quite a few have driven on the highway and seen trash blow in and blow on. Sometimes one happened to me, blow on my windshield and had trouble seeing. You know, it's just unbelievable. But we can do something about that in Maryland. Next slide, please. Litter, trash on the highways, is a breeding ground for rats and disease-causing bacteria. Litter discourages economic development also because it impacts real estate values. I want to say we had a major retailer invited to visit my district for economic development presentation, trying to attract them. And they drove down the road, the grass was high and the trash was, I said, you know, there's no way we're coming to this community. And they turned around on the highway and sent a text that they will not come for the meeting. We worked on that as part of my big push as senator for the last 2+ years, is to work with them. And so I must say, we're working with State Highway in our business district. And this past year, they did a great job in keeping the grass cut, the trees mulched, especially in the median, big wide median, and it's really neat. But we have a ways to go. We know they need more resources to do this statewide. It can be done, and we want to make sure that this bill will give them the resources to do that. Next slide, please. Mowing keeps grass and vegetation from interfering with driver's sight distance. This includes sight visibility. Well-maintained slopes and ditches have better drainage characteristics. If the grass is never mowed, ditches and storm systems can become choked with vegetation and trash and lose capacity to handle storm runoff. A lot of the times we see these heavy rains and roadways are flooded and folks have to be rescued, water rescued from their cars. It's caused by trash blocking the storm drains. And so if we pick that up, that have an impact on flooding in our great state. Next slide, please. Litter along our Maryland highways need to be collected on a regular and consistent basis. This will prevent safety, environmental, and economic hazards to our community. The grass along our Maryland highways need to be collected. The trash actually need to be collected on a regular and consistent basis. And of course, the grass cut. Next slide, please. I have some cited work, all this, present all these facts and this is cited, so you can pull it up at your perusal. Thank you, Madam Chair and members of the committee for your attention to this issue, very serious issue. And I open for any questions at whatever time you deem appropriate for me, Madam Chair. And I ask for your favorable consideration of Senate Bill 26.
Okay. Have you seen the fiscal note for Senate Bill 26? I see they're projecting 7.5 million impact by FY 2022, and then 10 million thereafter on an annualized basis. And they suggest that you may want to take a look at the fiscal note.
Yes, ma'am.
Frequency at which they currently cut, they tell you what they are having to spend and so on. So you want to take a look. As you recall, when a bill gets beyond a certain fiscal note and it's far below this one, budget and tax will have a role in determining from a fiscal perspective if it's doable during the current legislative session. Okay.
Yes, ma'am. I sure did look. I'm sorry, was that a question for me or?
No, I was just, well, I did ask if you had taken a look at your fiscal note.
Oh, yes, I have. Yes, ma'am. And it also talked about the small business effect will be meaningful because this will bring lots of employment into our state. You know, a lot of folks who work in landscaping, they really need the jobs, especially with our state. So there's a balance. And a lot of this money paid out for cleaning up our roadways will return into salaries and, of course, the taxes back to Maryland. So the net benefit is just tremendous. And could I just also say, Maryland is a great state for tourism. You know, I mean, go fishing on the Eastern Shore, you go to Ocean City, then you go out to our casinos in Prince George's County, and then you go skiing out in Western Maryland. We have great potential for tourism here. And when people come to Maryland to recreate, they should not see trash on the highways. So this will help our tourism industry tremendously also.
Right.
And I wish we could put a number on that.
Okay. Your main witness is Jennifer Roberts, and she has 5 minutes. And then there are 3 others who will have 2.5 minutes each. 2 others with 2.5 each. Okay, Ms. Roberts.
Thank you. Good afternoon, Chairwoman Kelly, Vice Chair Feldman, Senator Ellis, and members of the committee. Thank you for the opportunity to submit testimony to support Senate Bill 26. I'm here as an assistant professor of kinesiology and director of the Public Health Outcomes and Effects of the Built Environment Laboratory at the School of Public Health, University of Maryland, College Park. This important legislation will, quote, require the State Highway Administration to collect litter and mow the grass along state highways and certain interstate highways on a consistent and regular basis, unquote. Subsequently, Senate Bill 26 will require the administration to adjust the frequency of litter collection and lawn mowing throughout the seasons. Before I share with you why it is vitally important to support Senate Bill 26, I will tell you briefly about my background. My work and research examines the impact of built social and natural environments, including the institutional and structural inequities of these environments on the public health outcomes of marginalized communities. More specifically, I examine the dynamic relationship of these environments with physical activity, whether that be leisurely exercise or active transit, in order to understand complex health outcome patterns like disparities in obesity or diabetes among adults and children. More than 55 years ago, as a pet project of First Lady Bird Johnson, President Lyndon Johnson signed the Highway Beautification Act. This act encouraged scenic enhancement by providing funding for cleanup and green space landscaping along the roadways. However, the First Lady believed that beauty had a real social utility. She was quoted as saying, "The subject of beautification is like a tangled skein of wool. All the threads are interwoven: recreation and pollution, mental health, the crime rate, rapid transit in parks, and everything else leads to something." While First Lady Johnson spoke of these interwoven threads of pollution, health, and crime, my research, as well as the work of others, have identified and documented these significant associations. My study on the relationship between built or man-made environments and physical activity among children living throughout the Washington, D.C. region found that when there was not a lot of litter on the streets, children were more than 3 times likely to play at least 1 hour outside. And this level of physical activity not only has been recommended as the minimum level needed for children, but it translates to numerous positive health outcomes, such as a lower risk of obesity, diabetes, depression, cancer, and many more. In addition, adult physical activity research has also revealed that the absence of litter and crime was associated with higher rates of walkability and lower rates of obesity. Other research has also shown how neighborhood disorders such as the presence of litter or overgrown grass can negatively impact community health. In a Florida litter study, litter has been identified as a major indicator of neighborhood decline and disorder, which ultimately decrease property values and increase crime. Aside from the undeniable issue of aesthetics, litter can cause human health problems by attracting rats or other pests that may carry diseases, as well as wildlife health problems by degrading the aquatic and avian habitats. Furthermore, research has demonstrated that unmowed grasses are associated with higher levels of depression, anxiety, and stress for nearby residents. And overgrown grasses, along with the dense brush, have been shown to provide obscure spots and spaces for criminal and illicit activities. Many people don't recognize that the roads we walk on and drive on are owned and maintained by the state. I live in Montgomery County and work in Prince George's County, and the state roads that I travel most frequently are Baltimore Avenue, Route 1, University Boulevard, Route 193, and Colesville Road, Route 29. While these two counties are very different demographically, there's only a 1.5% difference in the percentage of persons living in poverty. High correlations of neighborhood disorder are routinely located in poor communities of color and or socially disadvantaged neighborhoods. Because I travel these roads on a regular basis, I notice how the litter piles up and the grass overgrows due to a lack of timely trash collection and grass mowing. Health disparities exist throughout Maryland, particularly in the 2 counties that I just mentioned. To name a few, there are race-based disparities in obesity, diabetes, and cardiovascular disease, whereby Black Maryland residents are 1.5 to twice as likely to have been diagnosed with these conditions in comparison to white Maryland residents. There is a growing body of literature supporting the argument that well-maintained areas help reduce these health disparities by promoting safe and activity-promoting areas. These areas can also be restorative natural settings to improve psychological and well-being for its residents. Therefore, I support Senate Bill 26.
Thank you very much. Are there any questions? Senator Battle?
Thank you, Madam Chair, and Ms. Roberts, thank you for your testimony. And in your testimony, it seemed like you were indicating that it's even worse in minority communities, picking up the trash and the mowing. But I just want to tell you, I represent the area that is Fort Meade and NSA. I have 60,000 people that go to work every day. And I will tell you, my ramps and my highway, 32, 295, 95, are just as bad as any other part of the state, if not worse. But I have a question, and I don't see anyone from State Highway here with us, but it seemed like it was worse during this pandemic. So the question may not be for you, Ms. Roberts, but maybe for Senator Ellis. Were there any conversations with State Highway about how the COVID pandemic has affected this cleanup and mowing?
Yes, ma'am. So on the road tour for MDOT, they came, they go around the state, each county, and they speak about the priorities of Maryland Department of Transportation, which State Highway is a part of the Maryland Department of Transportation. And so Secretary Slater mentioned that, because of COVID and budget issues and staffing issues, they have to cut back the trash pickup and the cut-in even more. So I have roads in my district, and like 210 I travel on, they probably pick up the trash when times are great, booming, and money's coming in. They pick up the trash probably 3 times a year on those roads. Now they're going to cut it back to what? Once? It's like when times are great, the trash is there. When times are so-called bad, more trash. How long will we put up with trash? I shouldn't answer a question with a question. I apologize.
Okay, Madam Chair, can I ask one more question?
Yes.
I just wonder what we can do as legislators to educate people about litter, because it seems like it's gotten worse in recent years, and it really does degrade the appearance of our community. So I think we need to be thinking about the bigger issue, and that's how to keep our constituents from throwing trash out onto the roads. Thank you.
Okay, thank you. All right, we're going next to Thomasina Coates. Oh,
I'm sorry, there's a hand raised. Senator Benson has her hand.
Senator Benson, you want to unmute yourself? You got to unmute. You got to unmute.
Okay. Hi there. Listen, I just want to ask a question. I want to make a statement, then ask the question. I'm inside the Beltway, most of my district. And I called State Highway Administration to complain about the trash and the problems that we were having with the grass, particularly with Martin Luther King Highway, because we need to respect Martin Luther King. If we're going to name a highway for someone, we need to respect the person that the highway is named for. When they didn't respond, I said, listen, here's what we will do. I'm going to come get in the car with you. We're going to ride along, and then I'm going to point these things out to you. So a small group of my constituents and I rode with them and showed them the problems that were being created. And they responded to every concern that we had, to be honest with you. They did. They were very responsive. The question I'm asking is, have you all sat down with Highway Administration? Have you all ridden with them to point these things out? But also, more importantly, I'm doing as much as I can to inform the citizens in my district as to how much it's costing them as taxpayers to deal with this trash issue, because it's costing taxpayers, and the trash goes down into the waterways and kill the fish. It ends up in the Chesapeake Bay. So I'm just wondering, what kind of public relations have we put in place to discourage people from throwing trash out the window. And have you all had a meeting with the highway administration?
Senator Besson, I'll answer that to the best of my ability. So continual meetings with State Highway. You know,
You have?
Yes, ma'am. My first year in office, the regional engineer came to Waldorf, my district office, and staff, and we had meeting with community leaders. And I indicated earlier, they worked on my major concern, which is our central business district. The major tax paid area was a mess, and they were really effective with that. Maybe say 5 miles of 301 through the Waldorf Business District. But the other roads, you know, I tell you, the funding, as indicated in their comments in the fiscal note, is not there for them to hire the staff to do the trash pickup statewide. I must say, our controller said a few months ago that his first action if he was elected as governor, will to clean up the roads in Maryland. So, you know, it's recognized throughout that this is a problem, but somehow we as a state is not really taking it serious to put the money in to clean up our state and to be proud when we have visitors come visit our homes and our state capital and our beautiful beaches, that they do not drive through trash. Somehow we have neglected that. You go to states like—
I know that is bugging you, but we are becoming kind of repetitive. We know you're upset about that, and you're letting us know how upset you really are.
I might want to add that in Prince George's County, Montgomery County, we work together, and we do understand clearly that the cost for picking up trash, we looked at the data a couple of years ago, it was close to $7 million, $7 million. But the question becomes, what is our role in educating the people who do this, the public? It seems to me that the public relations that prevail, that it's not present. That's the problem.
Okay.
Is that a question for me that requires?
I think it's more rhetorical question.
Yeah, it is. I'm sorry.
Senator Augustine.
Thank you, Madam Chair. Senator Ellis, I want to thank you for bringing forward this legislation, because this is a huge concern in my district, across the state. I share the things that you have said within that. Would you consider putting into your legislation some other things around educating the public about the problems of of litter education and stuff like that? So maybe we can get it coming from two different directions. We desperately need to get these roads cleaned up, no question. But would you be, what do you think about that?
Yeah, definitely, Senator Augustine, and picking up on what Senator Benson indicated, educating our citizens about the impact of opening the window and throwing trash out. You know, it's a very big thing, and we need a multifaceted attack on this problem. And I would not be repetitive, so I'll end it there.
Okay, I would definitely.
Okay, but you guys sound like you're on the same wavelength. You might want to get on your own work group to fix.
I agree. I'm willing to work with you on that, Senator. Thank you.
Thank you, Senator Augustine.
Are we going next to Thomasina Coates?
Thank you so much. Oh my God, what a great conversation. Thank you, Madam Chair, and the members of the committee for this opportunity. I am Thomasina Coates. I'm the County Commissioner for Charles County, elected to represent District 2. Today, I'm representing testimony as a lifelong resident and citizen of Charles County. I respectfully urge favorable support for SB State Highways 26, State Highways and Interstate Highways, litter collection and mowing, of course, with any amendments. Charles County, and I want to tell you a little bit about Charles County. It's known as Maryland's best kept secret. It's a combination of urban, suburban, and rural, attracting over 160,000 residents since its inception over 360 years ago. It's a thriving county, rich in culture, history, attractions, and diversity. It's surrounded by 18 miles of water, abundance of forestry, many historical sites, a 13-mile hiker-biker trail, marine sanctuary called Ghost Fleet, and many other attractions and businesses. Now that I have you envisioning the beautiful landscape of Charles County, now just imagine a long route, driving along Route 210 and 301, and you enter into Charles County and many other counties in the state of Maryland. Instead of seeing that beautiful oasis that I just described, you see overgrown grass and underbrush and litter along our highways. Most importantly, in some cases, the grass and underbrush have become a safety hazard. So I know that we've talked about litter. I want to talk about the safety hazard about the underbrush, the overgrown grass and underbrush. It obstructs visibility around corners and intersections. This obstruction includes overgrowth and the median as well. Our residents often express the love for purchasing their home in our county, but that conversation is soon overshadowed by overgrown grass and the lack of litter pickup, making our county sound less than desirable. This goes to say, as our weather patterns change due to global warming, and we know that, so does our rain and storm frequency, resulting in rapid grass growing. Now, we know that this happens primarily in the spring, summer, and early fall. It's for these reasons I urge favorable support of SB 26, providing a more frequent litter pickup and grass mowing schedule to keep the landscape of our beautiful county beautiful and, most importantly, safe. I thank you for this opportunity.
Thank you. Are there any questions? Okay, finally, we have Dexter Bordes.
Thank you, Madam Chair. My name is Dexter Bordes. I'm president of the Westlake Business Association. I'd like to thank Senator Ellis and all of you for an opportunity to present today. Route 301 is a major thoroughfare through our community. Any passenger that's passing through will get their impression of our community. It's what they see on Route 301. Bad maintenance on our median is projecting an image that we do not care. The current grass cutting schedule allows the grass to get too tall before cutting. There are times when the grass can be over 12 inches tall. This makes it difficult for the grass cutting crew to identify paper and trash in the medians before cutting. We end up with shredded paper, trash on both sides of the road. Tall grass clippings are not removed. They're blown into the wind and they accumulate in piles throughout the roadways until the rains come and then they wash into the storm drain systems. The root cause of the problem is the number of times the grass is cut per year. In our preliminary meeting with the state, we found that the state cut the grass 4 times a year. And oh, by the way, this is the meeting that Senator Ellis just mentioned a few minutes ago, that he pulled in the state. And oh, by the way, right after the meeting, they went out and cut the grass. But that doesn't maintain the grass all the time. At the time we were in the meeting, I think the grass is about 8 inches tall. And when they cut it 2 weeks later, it was probably 12 inches tall again. So we're not necessarily solving the problem by just putting pressure on them. The contracts need to be changed. We found that if you could cut the grass 8 to 10 times a year, we would be in sync with the rest of the county. If you get off the main roads, off the state roads into our county roads, our contracts say 10 times a year. And the litter and the mowing is much more groomed. This is not exceptional grooming. Most businesses and residences, in your residence, you probably cut your grass 20 to 25 times a year. The roads are maintained, roads that are maintained by the county, as I was saying, they have specific specifications to allow the contractors to maintain the medians by pruning the trees twice a year, mulching them once a year, and then replacing damaged trees, because in the high traffic areas, you're destined to have damaged trees. Our request is that we establish a maintenance program in the business district. It's not necessarily that you cut a place that's in more remote areas as you would in the business district. So you'd probably have to adjust the cuttings. But beyond 301, we have polished neighborhoods and citizens who really care about their community. There's nothing we can do about maintenance of 301 except pay our taxes, inspect the state of Maryland to do the maintenance. We're bringing this to your attention and request that you increase the number of cuts in the Waldorf Business District. Also, we request adequate mulching, pruning, and maintenance of our trees. Thank you for this opportunity and look forward to hearing back on the follow-up actions.
Thank you. Are there any questions? Okay, well, that ends the testimony on Senate Bill 26. We're going next to Senator Feldman, Senate Bill 458. Senator, you have the time that you need, and your 5-minute witness is Michael Huff. And
okay, thank you, Madam Chair. So Senate Bill 458 is a somewhat technical bill. I'll just put it out there. There's, to my knowledge, no opposition to the bill, and we've got some experts testifying behind me if there are any questions. But let me start by saying, so around the country, we have what are called federal home loan banks, which are essentially member-owned co-ops that provide financing to their members. And when we say members, we're talking about banks, credit unions, community development, financial institutions, and insurance companies. And these entities, these federal home loan banks, are really, really important to provide much needed liquidity into the financial ecosystem, and then credit options for their members. And so Maryland is part of a region of these banks that's serviced by the Federal Home Loan Bank of Atlanta. And you're going to hear gentlemen from that particular bank. In Maryland, we have 80 members in total, of which 5, Madam Chair, 5 are insurance companies. Now, what these entities, these federal home loan banks, they can provide really good collateral terms for its insured depository institution members, because under federal law and federal regulations, in the event those members fail, we've got in place a lot of federal banking and credit union laws and regulations. So for the insured deposit borrowers, members, there's a lot of certainty under federal law and federal regulations. By contrast, the insurance companies, I mentioned there's 5 in Maryland, are not subject to those same federal laws and regulations. They are subject to the receivership provisions in the insurance article of Maryland law, which creates a lot more uncertainty in the event the insurance company fails and goes into a receivership, specifically with regard to the ability of that federal home loan bank to go after the assets, the validly pledged assets that were pledged as security for a loan. And so as a result of this sort of discrepancy between your insured depository institutions and your insurance companies, these FHLBs require more collateral to secure a loan made to an insurance company when compared to collateral pledged by an insured depository member institution. So what this bill does, it amends our receivership provisions in the insurance article in Maryland to detail this FHLB's, the rights and responsibilities in terms of their ability to go after, again, the validly pledged secured collateral of the insurance company in the event the insurance company goes into a receivership, such as how long the bank would have to wait before going after that secured collateral, and some other changes. And so under the bill, one main provision is there's a 14-day stay period before they can go after the collateral, and some other changes. Here's the bottom line, Madam Chair, members of the committee. This change in this bill provides certainty and clarity into the situation of this receivership for the insurance companies. It puts the insurance company members on the same playing field as the insured depository members. And in turn, that helps the insurance company get more liquidity, have better credit options. Because of that certainty we're putting into Maryland insurance laws. And just a few other points, the National Association of Insurance Commissioners, Madam Chair, I know you're familiar with that organization. They've actually studied this topic and they've made a series of recommendations to all the states on this topic. And this bill meets or exceeds all those NIC recommendations. And right now, 19 states have moved forward based on those recommendations to put into law bills just like this. In our own region, Pennsylvania, Delaware, West Virginia have already moved forward with this bill. And I should also, all 5 of the Maryland domestic insurance company members and the Maryland Bankers Association all support HB 504. I'm not aware of any opposition to the bill. The only pushback at all you'll see from the MIA is a letter of concern, and they suggest that this 14-day stay period should be 30 days. And I think the experts may want to talk to that, but right now, the 19 states that have passed bills like this, 12 of the 19 have no stay provisions at all. The bank can go, the FHLB can go after the pledge collateral immediately. There's no 14-day stay. That's 12 of the 19. 4 other states only have 7-day stay periods. 2 have 10 days, and only 1 has as long as the 14 days that we have in this bill. And so to go to 30 would put us totally as an outlier, at least in the 19 states that have passed bills like this, Madam Chair. So with that, I'll maybe pass it on to the experts behind me. But again, there's no opposition. The only point of contention was that 14-day stay period. MIA suggesting go to 30, but I think the 14 days, again, is really quite generous relative to the other 19 states. So with that, I'd ask for favorable on Senate Bill 458.
Thank you. Are there any questions? Okay, hearing none, we're going to the 5-minute person from the Federal Home Loan Bank of Atlanta, Michael Huff.
Thank you, Madam Chair, Mr. Vice Chairman, and members of the committee. It's great to be with you today. My name is Michael Huff, and I'm appearing today on behalf of the Federal Home Loan Bank of Atlanta in support of the bill. And I'd like to thank Vice Chair Feldman for introducing the legislation. As Senator Feldman mentioned, the Federal Home Loan Bank of Atlanta is one of the 11 regional federal home loan banks created by Congress in 1932 to provide a reliable source of liquidity to our members through all market cycles. We're organized as cooperatives and have more than 800 members in our region, as Senator Feldman mentioned, including 80 in Maryland. Our members include banks, thrifts, credit unions, and insurance companies, as well as community development financial institutions. The legislation being discussed today amends Maryland law to align treatment of our insurance company members with federal law for our depository institutions, and importantly, aligning Maryland law with the other states have already adopted this legislation. The legislative language was developed in consultation with NAIC and has been passed now as of this week in 20 states. Arizona just passed it, signed into law yesterday by the governor of Arizona. And so it's also now being considered in 4 others. The legislation ensures that the Federal Home Loan Bank's priority in and timely access to the collateral that Maryland insurance companies voluntarily pledge to the Federal Home Loan Bank as a secured creditor. Further, it will limit the automatic stay injunction provisions to 14 days, which matches the longest stay of any of those 20 states. To provide some additional context, 13 of the states have no stay provision at all, and the remaining 7 range from 7 to 14, with only 1 state being at 14. So this legislation would put Maryland at the very top of the range among the other states. The legislation would create a transparent process for addressing obligations and the relationship between the home loan bank and the insurance company during a delinquency process. It also is important to note, it does not change the Federal Home Loan Bank's position relative to policyholders or other secured creditors, and it establishes a more predictable manner of resolution. Passage of this legislation would level the playing field for Maryland insurance companies, providing improved funding costs, additional types of eligible collateral, and reduced collateral requirements, which will free up additional capital for the company. Improved access to liquidity should also enhance the ability of the insurance company to serve Maryland policyholders and help create an even more stable and sound insurance system. So with that, thank you again for holding this hearing today, and I'm happy to address any questions that you may have.
Sure. Are there any questions? Okay, must have done a good job. Okay, we're going next to Rob Wilcox.
Hello and good afternoon, Madam Chair, Senator Feldman, and members of the committee. Again, I'm Rob Wilcox. I work for Legal and General Retirement America, which is a business unit within Banner Life. We, as an insurer member of the FHLB, support this legislation because of the benefits to our businesses and our policyholders. Banner Life has over $5 billion in assets and more than 1.3 million US customers. We are among the top 6 writers of term life insurance in the US with an in-force of over $783 billion. Banner Life is a healthy and highly rated life insurer with plans for steady and conservative growth in the years ahead. Being a member of the FHLB Atlanta affords us and our policyholders many benefits, including a reliable source of liquidity, balance sheet diversification, and inexpensive funding that can create surplus growth. All of the advances from the FHLB are collateralized by the borrower member. Right now, only certain asset classes are accepted as collateral, typically certain types of bonds that do not fluctuate much in value. This conservatism on the part of the FHLB is because under current insurance law, there is no certainty of the timing of settling the advance in an insurer's receivership, even though the FHLB has a perfected security interest in the collateral. This legislation creates certainty in the timing. With this certainty, the FHLB is willing to accept additional asset classes as collateral. If this legislation is enacted, Banner will be able to expand its relationship with the FHLB, supporting our plans for steady and conservative growth. Banner has been working with the FHLB on this legislation since last summer. We studied the analysis of the NAIC and reviewed the laws in the 19 other states that have enacted the legislation. In early October, we contacted the MIA to discuss the legislation and its support from the 5 Maryland insurer members. In December, in response to concerns expressed by the commissioner, the FHLB agreed to lengthen the stay on its ability to exercise collateral rights to 14 days, the longest stay of any of the 19 states. We are satisfied that the legislation as proposed fully addresses all of the recommendations of the NAIC and is one of the most favorable to the receiver among the 19 states that have enacted the legislation. On behalf of Banner and the 4 other Maryland domestic insurer members of the FHLB, we ask that you report Senate Bill 458 favorably. Thank you.
Thank you. You guys come with credentials that are well respected in Maryland when you talk about NAIC. Okay, are there any questions? Senator Augustine.
Thank you, Madam Chair. I'm just curious, how much additional leverage would this really, what does it really mean? I mean, since you do already have an underlying interest in these assets, what does it really mean as far as the additional leverage that you're going to be able to get based on this legislation?
Who would like to answer?
I'd be happy to.
I'll defer to Mr. Wilcox or Mr. Huff.
All right, Mr. Wilcox.
Thank you. I'd be happy to answer that, Madam Chair. And thank you for the question. It isn't so much a matter of leverage. It does allow us to post additional types of asset classes as collateral, thus expanding the scope of the relationship. The FHLB is seeking certainty in the timing of their ability to exercise their claiming rights. And when that uncertainty is reduced, they allow asset classes as collateral that aren't as conservative as the current limited set of assets are. So for us, it does expand the scope by a fair amount. by allowing us to post non-securities, certain types of non-securities, loans as collateral. Also, with this certainty that this legislation would provide the so-called haircuts that the FHLB imposes against loans and funding agreements would be reduced, thus improving the economics of the transaction for us and our policyholders.
But you can't share just, I mean, just a percentage or anything like that? You don't?
Oh, sure. Yeah. In percentages, if that's okay, it would roughly increase the scope of the potential partnership with the FHLB by 50%.
Wow. Okay. That's very helpful. Thank you.
Okay. Are there other questions? Okay. We're going next to Mindy Lehman, Maryland Bankers.
Thank you, Madam Chair, members of the committee. My name is Mindy Lehman. I'm the Senior Vice President for Government Relations for the Maryland Bankers Association. And I'd also like to thank Senator Feldman for his leadership on this important issue. Now, typically when we come before the committee, it's on behalf of our member banks, who you all know very well, the FDIC insured institutions who have branches in your communities. What might be less publicly known is this entity known as the Federal Home Loan Bank Atlanta. The region that Federal Home Loan Bank Atlanta represents, Maryland just happens to be the most northern part of that region. And all of the MBA member banks are also members of the Federal Home Loan Bank, along with credit unions and consumer development financial institutions. Now, since our members are all federally regulated, they already have this lien priority that's baked into that federal law. And as the previous testifiers have explained, what this bill does is it harmonizes Maryland's state law, as insurance companies are regulated at the state level, with that federal law. So then they become, have that same lien prioritization as the federally regulated entities, which are the Maryland banks, for example. Now, in terms of impact, which Senator Augustine asked the question, what this bill will do, a result of it will be that the insurance companies, for example, will be able to borrow at the same terms as banks and credit unions with the passage of this bill. And we ultimately believe that's a positive thing for the Maryland, for the entire system, the Federal Home Loan Bank system, of which the banks are members. So we're very pleased to be here in support of the bill, and I'm happy to answer any questions. Thank you.
Okay. Are there any questions? Okay, they're doing nicely. And we're going finally to Carmine D'Alessandro.
Thank you, Madam Chair. Vice Chair Feldman, and thank you for sponsoring the bill, members of the committee. My name is Carmine D'Alessandro. I'm Chief Legal Officer at Chesapeake Employers Insurance Company, Maryland's largest domestic workers' compensation carrier, here to support the bill. Obviously, Chesapeake values its relationship with the Federal Home Loan Bank. Not only does it support our policyholders, but as a workers' compensation insurer, it actually supports injured Maryland workers. And as an example, this was borne out in the early stages of the pandemic, when we didn't know how many of our businesses were going to close or how many were going to contract. We had no idea how much premium might stop coming in because of that, and we still had to support injured workers all over the state. So because there was a possible liquidity issue, we were able to use our membership with the bank, and in 36 hours had solved any potential liquidity issues. Now, fortunately, none of that came to pass, but it was a significant thing for us to be able to fall back on in a crisis like that. So we support any legislation that improves the Federal Home Bank's ability to carry out its mission. We also support the 14-day limit. As you heard, Arizona just passed legislation. More states are looking at this. By moving to 30, you could present a situation where all over the country, as more states adopt this, it would go from 0 to 30, which would leave all kinds of different time frames throughout the country, as opposed to locking it between that 0 and 14, which would be much more efficient. So we support the legislation. I obviously will adopt the testimony of the experts that preceded me. And with that, I thank you for your time.
Okay, are there any questions of Mr. D'Alessandro? Okay, Very informative hearing. And that ends the testimony on this bill. We're going finally to Senator Benson, Senate Bill 290, health insurers, out-of-pocket maximum and cost-sharing requirements calculations. Senator, you have the time that you need, and your 5-minute witness is Julia Boles, and all of the other witnesses have 2.5 minutes each. Oh, you want to unmute? You got to unmute, Senator. Unmute.
Okay.
Unmute. Yeah, now that's fine.
Thank you very much, Madam Chair. Good afternoon, and to the esteemed members of the Finance Committee. Senate Bill 290, Health Insurance, Out-of-Pocket Maximum and Cost-Sharing Requirements. Calculation requires all payments made by patients, either directly or on their behalf, to be counted toward their overall out-of-pocket maximum requirement or towards their deductible. This protects patients from receiving unexpected bills or treatment delays, since their insurance company only count payments made directly by the patient towards cost-sharing requirements. Charities and drug manufacturers offer copay assistance programs from individuals living with rare chronic conditions to help temper high prescription costs. At times, these costs can be as high as 20% to 50% of the cost of their medication. However, insurers are increasingly implementing copay accumulator programs. Copay accumulator programs stipulate that the insurer will not count copay assistance toward the patient's deductible or out-of-pocket maximum. In effect, this means that the insurer is double dipping by being paid once by the copay assistance program and then again from the patient's own pocket. Accumulator programs render copay assistance programs useless. Many individuals are unaware that their insurance company undergo this practice until it's too late. Worse, those with high deductible health plans are more at risk. I believe in protecting our most vulnerable citizens, the helpless, the hopeless, and the homeless. This bill protects those who are truly at their most vulnerable state, those living with chronic and often rare conditions, who suffer enough trying to live a normal lifestyle with their condition. The last thing one should have to worry about is whether their insurance company will cover the cost of the treatment that will save their life. Yet, when insurance companies utilize these co-payment accumulator programs, patients think that they have met their deductible when in fact they haven't. This puts an unnecessary burden on patients to figure out how to come up with the additional funds to pay for their treatment. This threatens continuity of the treatment and the patient's well-being. This bill has nothing to do with the cost of drugs. Senate Bill 290 is simply about fairness and equity for patients, especially those with chronic, costly conditions and those with limited means. This bill has no fiscal note and has bipartisan support. Therefore, I respectfully urge and request that the committee give this a favorable report. Senate Bill 290.
Thank you. Are there any questions to sponsor? Okay, if not, then we're going to her major proponent from the National Psoriasis Foundation, Julia Boles.
Thank you, Madam Chair, members of the committee, for allowing me to speak today. My name is Julia Bowles. I'm the Grassroots and Advocacy Manager at the National Psoriasis Foundation, representing 152,000 Marylanders living with psoriatic disease. I also live in Bethesda, Maryland, and am proud to be here on behalf of the Maryland All Copays Count Coalition, which is over 25 patient and provider organizations in support of Senate Bill 290. I want to start off by thanking Senator Benson for introducing this bill this year and her continued support of the patient community. With the COVID-19 pandemic causing financial hardship for Marylanders, this bill is especially important this year. As Senator Benson said, Senate Bill 290 very simply ensures that all payments made by or on behalf of patients are counted toward their deductibles and out-of-pocket maximums. As of now, we have seen this bill passed in 5 states, and we are expecting legislators across the country to take it up this year in recognition of the emerging problem, expecting upward of 20 states to consider this issue. The patients that we represent use copay assistance from nonprofits as well as manufacturers to help afford their out-of-pocket costs for treatments, which, as Senator Benson said, can be thousands of dollars a month. Historically, when a patient paid their out-of-pocket costs, they would using their own money as well as dollars from copay assistance. Every single dollar that was paid was counted by the insurance company toward their cost-sharing requirements. But a rise in these copay accumulator adjustment programs is harming patients by excluding money from copay assistance from counting toward their cost-sharing obligations. This is a discriminatory practice that allows payers to shirk their fiduciary responsibilities. Under an insurance plan, patients owe a deductible and out-of-pocket maximum before their full coverage kicks in. And copay assistance dollars help patients pay these out-of-pocket costs. But when health plans choose to exclude money from copay assistance, patients then have to pay the deductible again. I cannot imagine going to the pharmacy and being told that I owe my entire $3,000 deductible because my copay assistance wasn't counting. But unfortunately, this is the reality that many patients in Maryland are facing. This is an unfair practice, and at the end of the day, payers are shirking their fiduciary responsibility. I'd like to also take a moment to address some of the unsubstantiated arguments that have been made against ensuring all copays count. Opposition to Senate Bill 290 has argued that copay assistance increases healthcare spending by incentivizing patients to use brand name drugs. But I have 2 points I'd like to make on this claim. The first is that patients with chronic diseases, diabetes, HIV, arthritis, they don't have cheaper alternatives or generic options to manage their condition. The insurance companies and PBMs have cited an outdated New England Journal of Medicine paper that says that the availability of copay assistance increases the use of brand name drugs that have generics by 60%. But that study, which uses data from 2010, only looked at the very, very small market share of copay assistance for brand name drugs that have generics. More recent data by IQVIA from 2018 has shown that 99.6% of copay assistance, so in other words, almost 100% of copay assistance, is for treatments that do not have generic alternatives. Let me repeat that. So nearly all copay assistance is for treatments without generic alternatives. And therefore, the claim that there are cheaper alternatives for patients using copay assistance is unfounded. The second reason why this argument is faulty is that patients cannot access medications until their insurance company approves it. Patients aren't just secretly going around the insurance plan and getting access to brand name drugs just because assistance is available. It's the case that insurance companies already have utilization management tools, whether prior authorization or step therapy, and these tools are explicitly designed to drive patients towards lower cost treatments first. So only after an insurance company approves coverage for a treatment can a patient then use copay assistance to afford those out-of-pocket costs. So in the end, we understand that there are concerns about high drug costs and insurance reform, but with all of that said, at the end of the day, copay accumulator adjustment programs are not the solution to that problem. These programs leave patients in the middle of the healthcare reform debate by punishing them for needing high-cost treatments and seeking assistance to help afford them. I'd be happy to answer any questions from the committee and respectfully request a favorable report on Senate Bill 290, which very simply ensures that all copays count. Thank you.
Thank you. Are there any questions? Okay, then we're going next to Carrie Koenig.
Good afternoon. Thank you, Madam Chair and members of the committee for this opportunity to speak. My name is Carrie Koenig. I live in Odenton and I'm the parent of a child with hemophilia. I am employed at the Hemophilia Federation of America, but I'm here today to speak in my personal capacity in support of Senate Bill 290. My father has hemophilia and I myself am a carrier. My 10-year-old son, Nicholas, was diagnosed with severe hemophilia when he was just 2 days old. I knew that my son would need lifelong, high-cost treatment to live a healthy life. Nicholas began a regular regimen of intravenous infusions to prevent bleeding episodes after he experienced his first bleed at 11 months old. Bleeds can cause cumulative and irreversible damage, so preventing bleeds in Nicholas is key to preserving his lifetime health. Since there's no cure for hemophilia, preventing bleeds is, to prevent bleeds, he infuses a clotting factor on a regular ongoing basis. Even though Nicholas is a well-managed hemophiliac, the cost of his medication averages about $300,000 per year. Selecting health insurance for us is a balancing act. We have to weigh the premiums, the coverage for Nicholas's treatment, and the cost of the treatment itself. We rely on copay assistance to help us afford his life-saving treatment. We've selected a gold plan through the marketplace. And despite paying full premiums for the best coverage available, our out-of-pocket costs for Nicholas are still extremely high. Each and every year, we meet our deductible in the first month with our first prescription fill of the year, and we reach our out-of-pocket maximum very quickly. With hemophilia, copay assistance is truly the only way we're able to afford Nicholas's treatment. There are no generic versions for managing hemophilia, no low-cost options. All hemophilia treatments are branded biologics and very expensive. If we were suddenly hit with an unexpected bill when we believed our copay assistance was counting towards our out-of-pocket expenses, we would not be able to continue to afford Nicholas's in-home treatment. We would then be forced to treat his bleeds as they occur instead of preventing bleeds, and we would have to go to the ER for those treatments. This would dramatically increase healthcare costs all around. It would be bad for Nicholas's health. It would be terrible for his education and impact his ability to be a regular kid. It would also ultimately create incredible, irreversible financial hardship for my family. I respectfully request that the committee support Senate Bill 290 and protect Nicholas and other Marylanders with chronic conditions by ensuring that all copays, even those made by copay assistance, count. I'd be happy to answer any questions.
Are there any questions of this witness? Thanks for sharing. Okay, we're going next to Angus Worthing, from the Arthritis and Rheumatism.
Thank you, Madam Chair. Angus Worthing, on behalf of Arthritis and Rheumatism Associates and our patients. Currently, about 2% of Americans take specialty drugs, which means about 100,000 Marylanders could be affected by this bill and lose access to their medications if it's not enacted. This is about 20%. This includes 20% of my patients who generally require thousands of dollars a year of copay assistance. And I'll say it's heartbreaking to see the look on their faces when they realize that the medications they've been taking that rescued them from disabling pain from autoimmune disease might not be available to them. When autoimmune diseases flare, I prescribe steroids or immune suppressing medications, and sometimes we hospitalize people. This is arguably the worst time in history in the pandemic to immunosuppress or hospitalize people. Also want to mention how insurers implement these tactics by requiring me to report my patient's copay assistance data, which places me in conflict with my patient's welfare. disrupts the patient-doctor relationship, and it violates the AMA Code of Medical Ethics. As has been noted, the insurance industry opposed this legislation last year on the basis that it would promote high-cost drugs over lower-cost drugs, and that the federal government prohibits copay programs. I find this argument distorts reality. My patients have already been failed by the less expensive drugs or generic drugs. Medicare beneficiaries don't need copay assistance programs for drugs that are given in the doctor's office because they have supplemental insurance to pay their copays. And finally, Maryland's largest insurer will not cover the cheaper versions of specialty drugs in rheumatology biosimilars because of the secretive rebates that it receives and the PBM receives. And the rebates increase drug prices, according to HHS. Right now, the nation's largest insurer has a copay accumulator policy on hold, paused right now as of January 1st, effectively waiting for you and other legislatures around the country and to see what is done this year. I ask you to please protect Marylanders, our patients, from this sword of Damocles, the way that Virginia and other states currently do. Appreciate this opportunity and happy to answer any questions.
Are there any questions? Okay. Let's go to Carrie Koenig.
She already spoke. Stephen.
Oh, did she already?
Number 5.
Okay. All right. We're going to Stephen Weiner.
Hello. Hopefully I don't look like a cat. If ever, am I coming across? Okay.
Yes.
Okay. My name is Steve Weiner. I am a pharmacist in Baltimore City. I own 2 pharmacies. I'm testifying on behalf of myself and Epic Pharmacies. And I thank the committee for being able to testify. Epic Pharmacies supports Senate Bill 290. And we thank Senator Benson for supporting this legislation. Copay accumulator programs do 3 main things. They make patients confused and cause anger. They do curb drug spending, but often for the wrong reasons. That drug spending, when a patient can't be compliant, will shift that spending to maybe hospitalization expenses as opposed to drugs. And along with that, lastly, patient adherence plummets. I take Prilosec, me personally. The more I deal with drug legislation, the more Prilosec I take. But I take Prilosec. And if my payer doesn't want me to take Prilosec, they can incentivize me to take another stomach medicine. And they're all similar. It really doesn't matter. And they might get a kickback or rebate if I take Protonix or something else. And live and be happy, I switch because the formulary says I should. The patients I treat with HIV infection, the other patients that get specialty drugs, they don't have the liberty of switching a stomach ulcer medicine that's the same thing. The therapy is highly specialized. So this argument that we're moving tiers to benefit the patient for equal treatments, it's not the case with specialty drugs. And when they can't afford it, they don't take it. They're non-adherent. It's not a question of less. They just can't afford it. And I see it. I say it's $200 and I get a deer in the headlights look. And then they say, I'll pick it up later. And they don't pick it up later. So why wouldn't a payer want this? They get to inflate deductibles. It's human nature. You don't criticize a predator. They do what they're supposed to do. But we're here to protect people. The legislature is here to protect patients. I apologize. I strongly encourage and wish the committee would support Senate Bill 290. And I thank you for letting me testify. And I am a drug expert, so I'm ready for questions.
Okay. Are there any questions of this witness? Okay.
Madam Chair.
Yes. Okay,
Madam Chair,
Rich.
Senator Bidle.
Senator Bidle.
Thank you. To our pharmacist, Mr. Reiner, that just spoke, can you give me like a real life example of how this works when there's a copay? I guess a copay comes from a manufacturer or from some other program.
Sure. So a prescription comes and there is often a deductible part of the insurance benefit and a copay part of the benefit. I deal with two things. I deal with manufacturer coupon programs. If a patient presents that will absorb a good part of that deductible. We also deal with nonprofits like Healthcare for the Homeless that will pay for copays for patients that really have no means of paying. Currently, in Maryland, at least in my experience in Baltimore City, copay accumulator programs have not been enacted for most plans. So what will happen is the deductible and the high copay will get covered by a manufacturer program. And now the patient can get their diabetes medicine. Often generic medications will not be covered by these programs. So the brand name manufacturer has absorbed part of that patient share. And now they're able to get their metformin for diabetes or some of their insulins because the expensive HIV drug, by way of example, had high copays and the manufacturer helped those patients take care of the patient cost share. With the accumulator program, the $150 deductibles or copays would not count. And now on top of that, the patient would have to pay. And it's estimated if these programs are enacted, the payer won't really kick in and pay anything until month 11 and 12. So what do you need insurance for? So that's been my experience.
Thank you. Thank you.
Okay, are there any other questions? Okay. We're going next to Brett Leninger, and this is an unfavorable.
Thank you, Madam Chair and members of the committee. Brett Leininger here on behalf of Kaiser Permanente, testifying respectfully in opposition to Senate Bill 290. The bill creates unintended consequences that maintain high cost of prescription drugs and increases health insurance premiums. The drug companies use coupons, as was discussed, and other mechanisms to pay consumers out-of-pocket costs, while at the same time charging the health plan the full price of increasingly higher priced drugs. The inflation costs are reflected to consumers in the form of premium increases, and this legislation would exacerbate that dynamic by requiring plans to count those payments towards the out-of-pocket cost requirements. The Medicare and Medicaid have prohibited this practice for sound policy reasons. And we think that instead of offering coupons and discount cards, manufacturers should simply lower their drug costs. Now, the General Assembly in the last couple of years has taken other innovative steps to address the high cost of prescriptions, most notably the establishment of the Prescription Drug Affordability Board, and legislation will be considered this session to fully fund it. Kaiser Permanente presented to the board this fall about prescription drug pricing and looks forward to continuing to work closely with the board as requested. And we think that is the forum to address what is really at the heart of the problem, which is the increased drug costs. With that, I'll conclude my testimony.
Thank you. Are there any questions? Brett, if for some reason the Prescription Drug Affordability Board legislation doesn't make it through, what do you see as a backup? I mean, these families are suffering.
Well, I do know that on the there this notice of benefit and payment parameters final rule, which permitted but did not require carriers to not requiring coupons and other forms of financial to be counted towards annual limitation on costs. So that policy decision has been made that it's permissive. And I think it's on a case-by-case basis. But the board is operating. I think it's just for longer-term funding issues. And there is also an assessment on a wide array of stakeholders that is funding it for the initial startup phase, which I don't know what the exact dollar amounts, and maybe others on the panel would know, but it's a significant amount of money that's already being assessed. So that's more for a long-term approach.
Okay, are there any other questions? Senator Benson. Now you got to unmute.
You
unmute.
I want to say hi, Brett.
Hi.
It's good to see you. It's good to see you. But listen, we have done the research. There has been no evidence that we know that this bill is going to cause an increase in prescriptive drug. What you're saying to us, we have not found that to be true. Where are you getting this? Where are you getting this information? I'm trying to figure out where did you get the evidence that points to the fact that it's going to be more costly to the little people that we're trying to take care of?
The cost of this does not address the cost. The underlying problem is the cost of the drugs. And the issue is that the carriers are paying for the cost of those drugs. And if you really want to get to the heart of the problem, it's addressed the ever increasing prices of the drugs themselves.
You're talking about pharmaceutical companies?
Yes, the drug manufacturer. I'm sorry.
You point to them, and they're passing the cost on to Casa Permanente.
Well, that's exactly right.
But it's not impacting the little people that need this to be taken care of. Is that what I?
And well, the prescription drug affordability board is designed exactly to address the affordability of prescription drugs, which ultimately will impact the consumer in a very positive way through its work.
See, I'm trying to protect people like Carrie here, who testified. Did you hear her compelling testimony?
Yes, ma'am.
That's who we're trying to protect. We're trying to take care. We're trying to keep the doctor who testified. Those are the people we're trying to take care of. I'm trying to figure out.
As is the affordability board, it's the only state in the nation that has done something like this, and it's just getting started. We just think that the appropriate venue for that is to deal with it in that comprehensive approach.
So what would you suggest? That we not pass this bill that's designed to benefit the little people?
I think the best approach is to go through the board that was just recently created.
And not pay any.
I will tell you that Senator Feldman and Delegate Tina Melnick given basic leadership for the state of Maryland in terms of that initiative. You might want to talk to them further. Senator Klossmeyer. I saw hers too. All right. We'll get to Senator Klossmeyer and we'll get to Senator Kramer. You got to unmute.
I was just raising my hand about the affordability board. That's all. That
okay.
Senator Augustine and I worked so hard on, but I see Senator Kramer has his hand up.
Okay. All right, Senator Kramer.
All righty then. Thank you. Brett, refresh my memory with the affordability board and prescription drug prices. Is that going to be looking at across the board for all entities, or is it limited to state employees that as the legislation passed? Could you refresh my memory on that?
I don't have that in front of me, but my recollection was that it was over a broad spectrum.
And that it would affect everyone, not just the state contracts for employees and pharmaceuticals, as it relates to state employees, and maybe Senator Feldman could refresh my memory because, I mean, I think that goes directly to the heart of what Senator Benson is looking to accomplish here. So I'm not sure that the Drug Affordability Board is the answer. I know there's a lot of finger pointing within the pharmaceutical industry as to who is at fault and the source of the problem, but clearly the testimony that we've heard this afternoon is compelling, and I think there is logic and reason to acting on the legislation that Senator Benson has before us. But thank you for that. Thank you, Madam Chair.
Okay, are there any other questions? Okay, then we're going to Neil Carthanis.
Good afternoon, Madam Chair and members of the committee. My name is Neil Carcanis here on behalf of the League of Life and Health Insurers of Maryland and America's Health Insurance Plans to respectfully oppose Senate Bill 290. Before I get into my testimony, I want to say hello to Dr. Weiner. He gave me my flu shot this year. I didn't realize he would be at this hearing, so thank you, sir. But it is good to see you all today. First of all, I do appreciate what Senator Benson is trying to do with this bill. It would certainly lower the out-of-pocket costs for patients through the use of coupons that they could apply towards their out-of-pocket spend. And that reason is because consumers need these coupons because drugs are so expensive, like Mr. Langer said. Unfortunately, these coupons do ultimately incentivize the use of high-cost drugs rather than the appropriate, cheaper alternatives, which ultimately does drive up the cost of care for the system as a whole. And we see those costs in premiums and just our overall spend. And so these coupons are wolves in sheep's clothing. And as Mr. Langer said, these coupons have been banned from Medicare and Medicaid and have been called an illegal kickback scheme. Carriers are not double dipping at all. I heard that comment earlier and I double checked, that's not happening whatsoever. And actually HGO had their pharmaceutical subcommittee yesterday. And their executive director of the Prescription Drug Affordability Board actually stated that coupons, quote, coupons just short circuit the tools carriers use to keep drug costs lower, end quote. I certainly sympathize with the proponents who are having to deal with very expensive drugs. I get it. But what we should be doing is allowing the Prescription Drug Affordability Board to do its work to help Maryland reduce our drug spend. Like I said, this bill would ultimately incentivize the use of expensive drugs and increase their overall cost of care. And so let's driving the spend, which is the cost of drug itself. Senator Kramer, I just looked up the Prescription Drug Affordability Boards, what they're supposed to do. So they're required to study the entire pharmaceutical distribution and payment system in Maryland and offer the policy options being used in other states and countries to lower the list price of pharmaceuticals. This includes setting upper payment limits, using reverse auction marketplaces, and implementing bulk purchasing process. They'll be having a study and there will be recommendations for legislative action. So I do agree with Mr. Laninger. That is actually a really great venue for this issue and for many others. So with that, I respectfully submit an opposition to Senate Bill 290 and ask for an unfavorable report.
Let me ask this for either of you who's recommended the Prescription Drug Affordability Board. What about timing? How long will the people who are presenting today, because they are in dire circumstances and they have significant pharmaceutical needs, which are so too costly to bear, how long might they be waiting for the board to really begin to have impact?
So I would need to go back and look at their deadlines and whatnot. I know that they hired their executive director fairly recently in the last month or so. And I believe they are, they're required to report to the legislature by the end of the year. Brett, do you know differently?
Madam Chair, let me just step in. So first of all, that board, just got going because of all the dispute we had with the governor over the funding. In fact, that was one of the veto overrides. We literally up and Van Mitchell had to, they actually had to borrow money to just get it going. They've had like just maybe some initial organizational meetings. So they're a long way from, you know, anything and producing anything concrete. And then also to Senator Kramer's point, we did at the end limit that bill in terms of its scope. And so Senator Kramer mentioned state government scope. The original bill was broad and applied to everybody. So I think before we're placing too much faith in this board, the scope was limited at the end. The funding has been kind of mucked up with vetoes. So we're behind the ball in terms of anything concrete in all candor. And I have a lot of respect for Van Mitchell. They did hire an executive director, but that just happened within the last couple of months. So
do you think that, Senator Feldman, that a work group between this committee and the House committee might come up with something that's interim until it is able to be up and to work, and we could maybe use this bill as a vehicle just for an interim period?
I mean, I don't, you know, that's an interesting suggestion. I don't want to say, I'd have to talk to, you know, some of the folks in HGO and Van Mitchell, the chair, and, you know, because we don't want to be raining on their parade because they are getting going. But on the other hand, I would not place too much. I don't think that's going to have much impact in the near term on you know, what Kerry Koenig or, you know, some of the witnesses we had a little earlier. I think their situation's not going to be remedied by the work of that board anytime soon. But.
And I understand the position of those who have testified unfavorably today, but I would ask you to go back to your folks to see if you could help us during an interim period to this prescription affordability board can be up and running. Because in the meanwhile, their Maryland family is really hurting. So if you could help us work on something that we could get a work group going on just to get us through till it's up and going, we would appreciate. Are there other questions?
I think we have another witness.
Oh, yeah, I'm about to call Neil. Wait a minute. No, wait a minute. We have Camille Besh. And then following Camille will be Michael Johansson.
Madam Chair, I think Senators Kramer and Bottle were itching to ask a question or two. I see their hands up.
Okay, all right, fine, let's do that. Senator Kramer and then Senator Bottle.
Thank you, Madam Chair. I think Senator Feldman addressed the point I was trying to make. I was going to ask Neil to please confirm if my recollection was correct of the limited scope of what the pharmacy board might be doing once it's even up and operational. I think that has all been clarified by Senator Feldman. So I would point out that I think the reliance on the board as being advocated by both Brett and Neil might be a little bit misplaced. And but the chair has made the suggestion that there be a serious look at maybe doing something to start to address the need of the people we've heard from today, pending some future opportunities that the board might be able to address. But that's not going to come to fruition anytime soon. So I think there's work that needs to be done here. Thank you, Madam Chair.
Thank you, and Senator Bottle.
Thank you, Madam Chair. My question is for Ms. Koenig. The number that you quoted for your son's drugs was just astronomical to me, $300,000 a year. Are there generic drugs that you can use, or there's only one drug that is what helps your son?
No, there are no generics for hemophilia treatment across the board, only brand specific biologics, brand name specific biologics. And even that, we have very few options.
So if we would pass this bill, it does not encourage manufacturers to charge more or encourage higher cost drugs because you don't have any other option, correct?
We don't have any other options.
Thank you, Ms. Koenig.
Thank you.
For those asking this kind of question, do you think that even with this bill, if we were trying to reconstruct it, that limiting whatever you might recommend to those who really don't have any other options during an interim period till at least the affordability board is up and running might be helpful?
Madam Chair, I would
Well,
certainly.
those are questions. We'll take it up if we have a group meeting. Okay. All right. And Ms. Freshy and then Michael Johansson, if he's here.
Hi, Mr. Johansson is currently testifying in HGO, so it'll just be today. Thank you very much. My name is Camille Fett, for the record. Hello, Madam Chair, Mr. Vice Chair, and members of the Finance Committee. Always a delight to see every one of you. I'm here on behalf of PCMA, the Pharmaceutical Care Management Association, which is the national association representing PBMs or pharmaceutical benefit managers. Now, the PBM, as you know, is the drug benefit that you have in your healthcare plan. It's usually a separate company from the health insurance company itself. The issue presented by 290, which to be clear, we're here opposing, is that it thwarts the plan design issue. The PBM works with the health insurance carrier and usually the employer or the entity that is requesting the creation of a health insurance plan to design a plan that tries to put in, one of the things it tries to do is put the patients in similarly situated situations. So you have a plan designed with a formulary that encourages patients to use generic drugs or use cheaper alternatives where available, and has other instruments that have been mentioned before, where you have to get prior approvals and where you have to potentially do step therapy in order to keep the whole pool of people that are in the plan to keep drug costs down as much as possible. Copay accumulators thwart plan design. And they, in places where there are generic alternatives, they do keep patients on more expensive drugs. I know that's not the case for every single drug out there or every single condition out there. But what the coupon accumulators do is they really work for the benefit of the people where the pharmaceutical drug manufacturer has created a coupon for a particular drug or a particular condition, has allowed those people to not share the burden of the cost. The burden of that cost is then shared by other people that take on more of the cost in the healthcare plan itself. So what it does is it rebalances, thwarts the design of the plan. That's one of the major issues with this bill. So, and it's not something that the PBM can be aware of who's going to be taking the coupon or what coupons will be offered. Not every drug has a coupon associated with it. Not every expensive drug has a coupon associated with it. And it's unfair that the people that are lucky enough to be able to access coupon accumulator drugs and to have that benefit put that cost burden on the other people in the plan that don't have that access. It is the pharmaceutical manufacturers who are the ones that create who note the list price, they create the price, and they also create the coupons for these drugs. So that is really where this issue is coming from. These plans are not means tested. There are patient assistance plans for people that cannot afford. These plans these copay accumulators are only for people that already have insurance. So we're already talking about the population that has insurance. They are not means tested, and they're not necessarily designed to help. They are not designed to help the poor or the uninsured. And as I mentioned before, these are considered illegal kickbacks when it comes to Medicare and Medicaid, even though they are allowed in parts in the commercial market. So with that, I'm happy to answer questions, but PCMA is here to respectfully oppose Senate Bill 290. Thank you.
I would say I find it interesting you present the pharmacy benefit managers as kind of the poor things in between, but you really are running the whole system between the manufacturers and everybody else. And you're pretty arbitrary very often in what you do, and you often change. I hear from pharmacists all the time in Maryland who been impacted significantly, and some having to close because of very arbitrary moves and many changes within a single contract year of the contractual relationship that you maintain with the pharmacy. So what can you do? You know there are people suffering and people who might die
Well, Madam Chair, first, I take umbrage with the notion that PBMs do things arbitrarily. PBMs come up with a plan design that creates a formulary. In doing that, they work with the entity that has requested a plan, usually a large employer like the state of Maryland, or a union or a corporation. And they've worked with the health insurance plan to create a plan to create a certain what people are going to have to pay and their principal, what they're going to have to pay in the deductibles. And that's why there are different levels of plans. And that's why people who work for different entities have different types of plans and different mixtures. Also depends on the group of people who are in the plan itself, depending on what's available and how the formulary works. So I do take umbrage with that. I don't think there's a notion of arbitrariness here. There are.
Well, I have a very different opinion, and I've been really studying this. Okay, any other questions? Okay, I think that ends. Oh, did we hear from Michael Johansson? Was he here? Okay, not here. That ends the testimony on this bill. Thank you. And that ends our hearing for today.